Bore da a croeso I gyfarfod bwrdd iechyd Prifysgol Cwm Taf Morgannwg. Hoffwn I estyn croeso cynnes I bawb sy'n gwylio heddiw. Good morning and welcome to the Cwm Taf Morgannwg University Health Board meeting. I'd like to extend a warm welcome to all who may be observing the meeting today. We are broadcasting today's meeting of the board live, providing the opportunity for anyone with internet access to observe in real time using a link that was shared via various channels prior to the meeting. I would like to therefore extend a welcome to all who may be observing the meeting today. In relation to today's proceedings, I'd like to note the following. For those observing, I just wanted to advise that we may not always be looking at the camera, as we are also referring to our board meeting papers throughout the meeting. We will also be taking a very short break at an appropriate time during the meeting, after about an hour at around 11 o'clock, and possibly again at 12 o'clock, depending on the timings. For board members, as you will be aware, questions on the consent agenda have been sought in advance of this meeting. I would like to welcome Leanne Davis, Senior Nurse, Ysbyty Cwm Rhondda, to the meeting. Leanne is here to introduce the patient and staff story at agenda item 2.1, which relates to the fire incident at Ysbyty Cwm Rhondda, which took place in early 2021. I would also like to welcome colleagues from the South Wales Fire and Rescue Service, Hugh Jakeway, Gary Davis and Jason Evans, the meeting, who will be providing board members with an overview of the events from their perspective in terms of how well the staff responded to the incident. I would like to extend my thanks to Gareth Robinson, Interim Chief Operating Officer, who will be leaving the Health Board in April, for the support he has provided to the board over the last 15 months. I would like to wish Gareth all the very best in his new role in Shropshire. Board members will be aware that Gethin Hughes has been appointed as the new Chief Operating Officer and will commence over Easter. I would also like to extend my thanks to Fiona Jenkins, Interim Director of Therapies and Health Sciences, for the support she has provided to the board since November 2020. Fiona returns to a substantive role at Cardiff and Vale University Health Board at the start of April, and I wish Fiona all the very best. Board members will be aware that Lauren Edwards has been appointed as the Permanent Director of Therapies and Health Science. To give you advance notice, at the end of today's meeting, I will be asking colleagues how you think we have done. There are a number of questions set out at the bottom of today's agenda that there are to act as a prompt for us to all consider as we work through the items for discussion today. I encourage all members to keep this in mind and offer reflections and suggestions at the end of the meeting to ensure we are working effectively as a board. I'm also asking all chairs of committees to adopt the same approach after each committee meeting of the board. Go to the next item then for 1.2 for apologies for absence. We've had apologies from our colleague Patsy Roseblade. 1.3 declarations of interest. We've not been notified of any additional declarations of interest prior to the meeting. Are there any declarations of interest from colleagues that anyone would like to raise now? No. Okay, then if I could go on to item number 2 then, please. We now receive a video of patient and staff story from Leanne Davis, Senior Nurse, Ysbyty Cwm Rhondda, which relates to the way in which staff responded to a fire incident which occurred at Ysbyty Cwm Rhondda at the start of 2021. Following the video, Leanne will hand over to colleagues from South Wales Fire and Rescue Service, who will share their views on the events of the day. So if I could invite Leanne into the meeting, please.
Hello, good morning everyone. Good morning. My name is Leanne Davis and I'm the Senior Nurse for the Inpatient Wards in Ysbyty Cwm Rhondda Community Hospital. Today I'm here to talk about an incident that occurred on the 7th of March 2021, whereby a fire broke out in Ysbyty Cwm Rhondda in one of our inpatient wards. The ward is Ward C3. Ward C3, just to give a little insight about the ward, is a 27-bedded inpatient ward where patients come for rehabilitation and discharge planning. At the night of the fire, the ward was at full capacity, so there was 27 patients there, plus 4 nursing staff and 1 nursing student. We're now going to show you an audio clip, giving you a little summary about the fire, and it'll also show a picture of the cubicle and the damage that was caused by the fire that morning.
In the early hours of Sunday morning on the 7th of March 2021, firefighters were called to reports of a fire within the cubicle on Ward C3 at Ysbyty Cwm Rhondda. Thankfully, due to the quick response and collective teamwork, staff were able to safely evacuate all 27 patients on the ward with no serious injuries reported. By utilising their fire training knowledge, staff followed safety protocols by using escape routes and closing fire doors, contain the fire and prevent it from spreading and endangering lives. As a result, the fire only affected one area of the ward and firefighters were able to extinguish the fire and secure the area. Following the fire, the staff involved were honoured with the South Wales Fire and Rescue Service Chief Fire Officer's Commendation Award. Following their quick thinking and brave actions, they received this on the 17th of August 2021. Staff involved were asked how their experience in dealing with the fire changed or impacted their role.
I am more aware of the role and responsibility of being fire officer. This incident has highlighted the importance of working as a team.
Staff involved were also asked if they learned or gained any more knowledge from being involved.
I am aware of where oxygen points are on the wards, as well as my own. The incident has highlighted the importance of fire training.
Has made me more aware of the fire safety procedures and has highlighted the importance of keeping up to date with the fire training, but has also shown that through working as a team in a controlled manner, aided the safe evacuation of both patients and staff.
I honestly feel we did a fantastic job and worked so well as a well-organised team.
Thank you. So just to go into summary really in a little bit more detail about the fire that occurred and obviously how the team managed that at the time of the incident. In the early hours of the morning, one of the staff nurses was walking past the cubicle and she noticed like a light in the cubicle. As she opened the door, she noticed that the bed was on fire and the patient was the other side of the bed in the cubicle. This staff member alerted all the staff on the ward that there was a fire. They came to assist, and with the help of the other staff, they were able to make sure the patient was safely assisted out of her cubicle. They then evacuated the 27 patients with support of staff off the other wards from Ward C3 into the adjoining corridors and on to the other wards within YCR. There were no injuries for staff or patients as a direct result of the fire. One of the key things that we've learnt from this is that without the teamwork, it would have been a physically impossible job to do. Having only been 4 staff on duty that night, without the help of the staff on the other wards, they wouldn't have been able to move those patients safely. Obviously, once the fire service was alerted to the fire, they were quickly on site to assist. By the time the fire service got there, the whole ward, all patients and staff were safely evacuated from the ward. Once the fire service and the estates department were able to extinguish the fire and make the area safe, then we were able to have a safety briefing, and from this then we obviously spoke about the incident, what we did, what we could have done, if there was anything, and any further actions. Also within the first hour of the fire, the investigation showed that the patient did actually start the fire. So the patient in the cubicle was the person that started the fire. And gratefully she didn't receive any injuries from the fire, and she was safely assisted onto one of the other wards. The efforts of everyone involved in this incident have been fantastic, from the staff on duty that night to the staff that came on duty that morning to assist and make sure that all the patients were safe, to the managers that came to site, to the fire and rescue service team. Everyone involved definitely made the incident much safer than what it could have been. So taking that into account, I do want to now introduce our South Wales Fire and Rescue colleagues. I know they're on the call now because I know they just want to give a bit of input into the fire incident. Thank you, Hugh.
Thank you, Leanne, and thanks, Chair and board members for contributing some valuable your time this morning to hear the story of the important fire that we had last year at Ysbyty Cwm Rhondda. Before I go into my little bit, what I'd like to do is introduce Area Manager Gary Davis, who was our incident commander for the evening, and he can give you a fire service perspective based on the video and the photographs that Leanne has already shared with you. We're having some technical issues here, so we'll not be able to share the PowerPoint presentation, but I think board members might be able to receive that after the meeting, if that could be circulated. So if it's okay, Chair, I'll pass you over to Area Manager Gary Davis and give you a fire service perspective, and then I'd just like to close our bit at the end then, if that's okay. Thank you.
Okay.
Yeah, thanks, Chief. Yeah, thanks, Chair. As the Chief said, I'm Gary Davis. I'm Head of Operations for South Wales Fire and Rescue Service. I received the call to the hospital at 04:10 hours on the 7th of March. Our appliances were in attendance within 4 minutes at the hospital, and what we were faced with as an incident was a well-developed fire in a compartment within the hospital. And as Leanne quickly brushed over, but I want to talk quite a bit about the actions of the team, Leanne's team at this incident, and equally my team. So I'll go into my team first. What we got to appreciate, the ward that was on fire was about 350 metres from the front doorway of the hospital. So the logistics involved in getting equipment and water to that incident to extinguish the fire was very testing for our team. But when you look at the comparison then of the quick reactions of the team in the hospital and what they carried out, which was patient evacuation and isolating the compartment by simply closing the door to the compartment, that stopped the fire spreading quite considerably. And when you talk about the fire and what Leanne alluded to in the photographs you've seen, you're talking of a fire which was a rapidly developed fire, which we call, which temperatures in that compartment at ceiling level would have been around 800 degrees Celsius. So a very rapidly forming fire. So to move 27 patients in the position they were, which Leanne, the majority of them were bed bound, so they were moved in their beds. And what we were faced with was that tail end of the evacuation, so we had to assist with that as well, and to deal with the fire was difficult for us. When we look at a large developed fire in that situation, and you know, some of the input off your staff of previous training they've had, they carried out that the requirements to a really high standard, which their training stepped in. And fortunately for me, being at the incident and post-incident and discussing with some of your colleagues, Leanne, I was able to get a measure of the responsibility and capability of that, and it was a very high standard. And one of your nursing staff, Leanne, mentioned to me that she'd been in the service over 40 years, never been faced with a situation like this, but her training kicked in and she was able to perform to a high standard. So that was absolutely awesome. When you look as well with a compartment of that size and trying to extinguish a compartment, we have to use quantities of water. So you know, we have to look at water damage to the rest of the property. So with that regard, we were able to extinguish the fire quickly because it was contained to one compartment. I will say very well developed, and you could see what I talk about a pattern of fire behaviour in that compartment. You can see that it spread quite quickly around that compartment and affected the ceiling area of that ward as well. But what with the fire doors reacting as they should have, the damage to the corridor and other rooms in that ward was very minimal. In fact, the only damage was to that actual room. So my teams worked with teams from the hospital as well to clear out that following the fire. Following the fire, we held a debrief on site as well, you know, with Leanne and the key stakeholders, and there was, you know, much praise and learning from the incident. So it you know, the positivity around the event, because of the reactions of both the fire teams and the hospital staff, was nothing short of amazing to be able to keep that hospital functioning after such a severe fire. We as firefighters face situations like this very often, so we're quite used to dealing with this. But I got to, you know, again turn to the team on duty that night. Their actions were nothing short of remarkable to be able to do what they done with, you know, without any injuries to staff or patients, to contain the fire to one compartment. And you know, in an environment where you've got to understand, it wasn't just the fire, the heat of 800 degrees Celsius, it was the smoke spread as well. So the smoke layer at times in there was down to waist level. And when we turned up, that's where some of the smoke was in the corridor leading to that fire. Working together, we limited the amount of water damage. Working with the teams in the hospital, they were absolutely brilliant that night, you know, outside of the ward staff as well. And we were able to empty the compartment, get it out of the way while there were no patients in that area. So we done a major cleanup as well to try and get, you know, to get the ward going back live as quickly as possible, because we fully appreciate the pressures on the hospital. So, you know, from me, as the incident commander, pulling up there to an incident that we don't face often in a hospital, you definitely made our jobs a lot easier. And I really appreciate the support you give me on the night, right away from during the incident to the post-incident debrief and considerations as well. Was nothing short of remarkable. So from me, thank you very much.
Thank you. Apologies, Chair. We slide an iPad around the table. It's the only method we could get into the meeting. We're having some technical issues there. Really thanks to Leanne and Gary, really outlining the terrific efforts really from the ward staff and everyone at Ysbyty Cymru Rhondda on that unfortunate morning. And also be remiss of me really not to thank our operational staff as well. That performed to an exceptionally high standard, and the standard that we've known to come and accept across South Wales Fire and Rescue Service. Chair, I've been the Chief Fire Officer of South Wales Fire and Rescue Service for a very proud 10 years, and I could probably count on one hand the number of occasions where I've had the pleasure to be able to present a Chief Fire Officer's framed letter of commendation for actions of individuals or a group of staff. And last summer, it was a pleasure for Gary, myself and some other managers from the service to attend Ysbyty Cymru Rhondda with Leanne and the team that were on a shift that evening to recognise their commitment to saving life, and I presented them with that framed letter of commendation. However, I didn't feel that just keeping this to a local level, I felt the actions of everyone involved, particularly Alma, who recognised what was going on with that patient in that room and rescued the patient successfully, and to Wynne, who initially started firefighting to the best that he could with the equipment he had, and then realising that was not going to put the fire out, as Gary described, a very well-developed fire, had the foresight to close the door, use the fire protection measures that you've invested in within that premises to allow the other patients to evacuate safely over that period of time. So I took it upon myself and I made a direct nomination to the Society of Protection of Life from Fire. And I put forward the actions and the roles that everyone took within that evening or that morning to get a successful resolution. And I'm proud to say that the Society for the Protection of Life from Fire have recognised the contribution that staff have made, and have presented, or allowing me to present a certificate on their behalf to all members of staff that performed above and beyond their duties to ensure that everyone remained safe as well. Not only that, staff from Ysbyty Cymru and firefighting crews of that evening when the fire was out made sure that the ward was clean, tidy, the room of origin was emptied, and the fact that the ward could get back to a continuity of care within hours is testament to the professionalism, commitment and the joint working that all our staff achieved on that morning. Chair, that's all I would like to say, and really congratulate Leanne and the team, and Paul, you and your team across Cwmtaf and especially at Ysbyty Cymru for outstanding actions on that morning. Thank you very much.
Thank you, Hugh. I'd just like to invite anybody now to see if they have any questions they'd like to ask us in relation to the fire.
Sorry, my apologies there. My microphone wasn't working. I'm struggling to get it, but I am working now. Can I just say in the first instance, thank you very much, for sharing with us quite an incredible story about how this fire was managed in Ysbyty Cymru. For the board to hear about the actions that were taken both by Leanne and her team, and certainly the actions from the fire service, and then acknowledging and recognising what Hugh and Gary have shared with us about the fantastic work that the hospital staff did in responding to this fire, and certainly in the interest of patient safety and the safety of the hospital. And well done for Leanne and her team for getting such a special award and recommendation for the work that they did. And I have to say, Hugh, it's noting your comments about how special this was of your 10 years in your chief officer role, about what Leanne and her team did within this is certainly, very commendable, and we certainly appreciate it as a health board. Can I just say to both the fire service and Leanne and her team, thank you very much for sharing with us this presentation this morning. It certainly helped us to understand some of the actions that go on in fire when you're having to manage a fire. It also helped us. I'm noting your comment, Hugh, about Paul and the team and the work that's done in relation to fire prevention or fire response. How we should do that within our health board is also a very positive note to take away from today's presentation. So can I say to both of you, thank you very, very much for this morning's presentation. Before finishing, is there any comments or questions that anybody would like to ask, either Leanne, Hugh or Gary? No.
Emrys, I would ask for comments on the sidebar.
All right, okay. I can see that. I've got a number of comments we've got on the sidebar. We've got Nicola saying how fantastic work by all, real evidence the importance of fire training. Certainly from Chris Beadle as well, it'd be amiss not to express my thanks to my local fire officers for the dedication assessing our buildings from a fire perspective and their efforts to train staff. And then if I could also invite both, in the first instance, can I invite Howell to offer a comment?
Thank you, Emrys. So just wanted to echo thanks to colleagues. So first of all, colleagues in the fire service for the continued support that we received from them, and obviously their responsiveness to this incident, and also to the advice that they give us continually in terms of the estate design and also the training that we provide to our staff. So thank you very much to Hugh and to Gary today for joining us, but also for the ongoing support that we receive, which is first class, as Hugh alluded to. Also wanted to echo thanks to Leanne, her team, and in particular Alma and Wynne, whose quick responses on the day really contributed to managing this fire and protecting life, as Hugh alluded to, and congratulations on your well-deserved commendations there as well. So huge thanks, Leanne, to you and your team. There's just 2 points I wanted to touch on, which have already been touched on in the comment bar, but they're worthy of amplifying, I think. One is around the importance of fire training. And as the board level director for fire for the health board, I think, you know, some of the actions that were taken by the team at YCR came as a direct result of the training that has been received over the years, both in terms of health board training, but also local fire training within the department, and that is really important and reinforces why we must get that right, and we must continue to do that. But also, as Chris has mentioned in the chat, how important it is that we get the design of our premises right from a fire safety perspective. And I know a huge amount of thought went into the design of YCR from a fire safety perspective, and I think it's probably right for me to mention Mark from the fire safety team, who does fantastic work in this area and is due to retire from the health board imminently, for all the work that he has done with local teams and on the estates front. So I just wanted to mention that. Thanks, Emrys.
Thank you, Howell. If I could then invite Gareth in, please.
Yeah, without covering the same ground as everybody else has, Leanne, you and I have spoken before about the appreciation, so thank you to you and your team. There's just two points that I'd like to make. One is on how we've learned from this as an organisation, which I think is useful for the board to hear. EPPR team, the health and safety team and fire, created a response to the learning from this event, shared it through the fire safety and health and safety committees, and also shared it with the executive leadership group, so that's then being shared across all of the ILGs and all business units, so that the learning from this event has been shared broadly. And Hal's obviously pointed out the importance of fire safety training, so that's really important, I think, for the board to understand. The second aspect, and it's a much softer aspect, absolutely right, we celebrate the staff that responded in the moment, but one of the things that was really obvious as well is by about 6 or 7 o'clock in the morning, the number of staff that weren't rostered to be at YCR that came in to support and help and just be there as sets of hands was, I think, a real recognition of the community spirit, both within that, you know, the hospital, but the broader community. And it's worth acknowledging that as well. The response from medical, nursing, other professionals, facilities, estates, fire, health and safety, everybody descended, even though they weren't rostered, they weren't on call. The number of people that came to help was really touching and really helpful during the course of the day in terms of the recovery, and that's worth acknowledging for you know, Team CTM as well.
Thank you, Gareth. If I could then invite Linda in, please.
Yes, very quickly, just wanted to build on what Gareth just said. So I had the privilege of my first in real life visits to the health board last week, I think it was, with Paul, and I met Leanne. So hi again, Leanne. And I just wanted to say, because Leanne took Paul and I through this, and we went and had a look where everything had happened and things, and I just wanted to say you did an amazing job on this, and I was not surprised, and I suppose what blew me away was that whole sense of community and the way that everybody pulled together. So it was really fantastic, and it was great to be able to go and meet you guys and hear this account firsthand, so thanks for that.
Okay. Thank you, Linda. Are there any final comments from Leanne or Hugh anyone would like to make before finishing this item?
Not only from me, Chair. I know the team. I've learned loads from the unfortunate incident. I think it's a really strong message, and I know Chris and the team and Paul will ensure this is used as a real life training. It's not an exercise. It did happen for real and happened in Cwmtaf, and I know moves are in for to use this to enhance training across the whole health board as well. So nothing more from me, and thanks for your time on a very busy agenda that you've already got, Chair. Thank you.
Okay, thank you. Anything from you, Linda, before I finish?
I'd just like to say, on behalf of myself and the staff in YCR, you know, I would like to thank everyone who was involved in the aftermath of the fire as well, because obviously there's been ongoing support provided to the staff members. It wasn't just a case of supporting them throughout the incident, it's been the aftercare, and I know a lot of people involved, so I just want to say thank you. And from my perspective, thank you for your time today and obviously listening to our story.
Okay, and just to just to close, thank you very much, Leanne. Thank you, Hugh and Gary, for a very, very, quite an incredible story, and it's good to see the positive learning that's come out from that as well. So thank you. Okay, board, if I could go on to the next agenda item then, please. And that is agenda item 3, and it's related to the consent agenda. To ensure we focus on business critical activity and discussions at this time, we continue to use the consent agenda for this meeting. I should like to inform all colleagues of a slight change in approach to receipt of highlight reports from board committees. These will now routinely be included in the consent agenda for formal noting and will be placed on the main agenda for discussion only when there are specific areas identified in the report for escalation to the board. I am assuming that everyone has read all the papers under the consent section. Are there any issues that anyone wishes to move on from the consent agenda to the main agenda for discussion, please? Okay, can I then therefore propose that all members present are happy to approve and note all items as requested? If I could then move on to the agenda proper, on to item number 4, please. Are there any matters arising not considered on the action log? No. Okay, can then I then go on to item number 5 on integrated governance and assurance, please, and on to 5.1 on the Chief Executive's report, and I'd like to invite Paul Mears to present the report which members have been asked to note.
Thanks, Emrys. Good morning, everybody. Obviously, my report contains a couple of further thank yous to Gareth and Fiona. I just wanted to add my thanks to those of Emrys, to Gareth for his leadership of the operational teams through probably one of the most challenging times at which anybody can take on an operational role in the health service, and Gareth has been with us since January last year and helped lead us through some really challenging operational situations over the past 15 months or so. So I'm really grateful to Gareth for his support and leadership over those times, and wish him well in his new role in Shropshire. And also thank you to Fiona for her support. Fiona, as colleagues will know, stepped into the breach and not long after I joined CTM, and has brought about a significant change in the way in which therapies and health sciences are represented and their voices heard more strongly, I think, than ever within CTM, and has also established a really good leadership structure around the therapies and health sciences teams, which I think will see us in a very positive, put us in a positive situation now as we move forward under Lauren's leadership over the next period. So thank you to Fiona also for her time, not just around the therapies and health science leadership, but for her support to the exec team, and also some of the wider roles that she's undertaken, particularly regarding things like stroke, ophthalmology, many of which we will continue to work very closely with her in her role back in Cardiff. So thank you to them both. In terms of other items, just to bring to your attention, obviously colleagues will know we continue to have some significant challenges operationally linked to demand pressures and also the ongoing management of COVID. This culminated in a particularly challenging time back in March, where we had to call a business continuity incident, which I think, from those of you reading the media, we're not unique in those pressures. There are many other neighbouring health boards similarly experiencing challenges at the moment of that nature. And consequently to this, there was a focus from Welsh Government and a risk summit that was called, bringing together health boards, Stretch the Social Services, to talk about some of the pressures across whole systems across Wales. This led to a reset week, or 2 weeks in fact, between the 2nd and 16th of March, where all health boards in Wales and other trusts and also social care organisations focused in for 2 weeks on looking at how we could get a greater understanding of what was impacting patient flow across our system, A lot of work was done through those 2 weeks, and thank you to Gareth and Sarah James, his Deputy Chief Operating Officer, who led the response from CTM. A really good opportunity for us to work closely with our colleagues in social care, particularly, but also internally within our organisation to think about how we could look at where there were delays, anything we could be doing further to improve our performance. I think it's fair to say that there wasn't a completely transformed performance during those 2 weeks, but it did flush out very much, I think, some internal process things that could be improved for us as a health board, but also some further work to do with colleagues in social care, and those conversations continue now with our colleagues in social care, as well as the internal improvement work that is underway across our sites. Also just wanted to alert colleagues to the recent review by the GIRFT team. So GIRFT stands for Getting It Right First Time. This is a programme of peer reviews that have been undertaken in England in many specialties, and also in Wales, where we've had periodic input from the GIRFT team in a number of specialties. The NHS in Wales has commissioned the GIRFT team, led by Professor Tim Briggs, who leads on orthopaedics, to come and review orthopaedic services across Wales. And as part of that programme, he visited CTM recently and met with our colleagues in orthopaedics to talk about how we can look at our orthopaedic services across the health board, but also how we can maximise opportunities to work collaboratively with neighbouring health boards to try and tackle some of the significant backlogs that we have in orthopaedic care here in CTM. It was, I think, probably quite a challenging session in many ways, and these sessions quite often are, because that's the purpose of having some external scrutiny, but I think also a positive session in terms of the willingness from our clinicians to think differently about how we provide services across our own 3 sites, but also how we can work in a different way with our neighbouring health boards, and that review work is still going on. There's feedback being collated at the moment, and there will be an overall report produced for NHS Wales, and also individual reports for each health board on proposals, which we will then take forward with our own local teams. And I think also opportunely it fits with our work that we're doing on the clinical services strategy as well, so it will help inform the clinical services work for orthopaedics as we move forward with the strategy work. Those are the key points I wanted to just raise, Emrys, but happy to take any questions if there are any.
Okay, thank you, Paul. Are there any questions or comments for Paul? No. If I could then go on to the next item, please, which is the Board Assurance Framework and Risk Appetite Statement. I'd like to invite Callie Hamblin to present the report, which members have been asked to approve.
Thank you, Chair. As the board will be aware, the Board Assurance Framework has been jointly developed by ourselves and the Good Governance Institute, and you'll be aware that I shared a draft with board members at the board development session in February. At that session, we socialised the Board Assurance Framework, revised risk appetite statement and revised risk scoring and matrix, and we allowed then a 2-week consultation on the drafts for board members to comment. So there was some changes that we've made since the presentation to the board development session. We reframed the articulation of some of the strategic risks, so I'm hoping the board are happy that they now better reflect our strategic goals and our strategic risks within the organisation. We've added an additional risk around workforce and recruitment and retention, because we recognise that at the board development session is something that we should pull out perhaps in its own strategic risk. So we have done that. We've also referenced the risk enablers within each section, which I know again was a point raised at the board development session. And we've also changed the ministerial priorities section to national priorities, so we broadened the scope of what can be included there. So there are no changes to the risk appetite statement or risk domain matrix following the consultation, so the copies you've got in your packs today remain as you saw at the board development session. You'll see on the Board Assurance Framework within your packs that there is a watermark of an example, and we've kept that in there because the Board Assurance Framework before you is just an illustrative example of what it will be like coming back to board. So there will be an opportunity, if the board approve it today, between now and the May board, for us to work closely with our executive colleagues to reframe and update each of the strategic risks that sit underneath it, and bring back a BAF to you in May. It will continue to evolve. This is a new approach for us as a board, so it will continue to strengthen, and we'll continue to keep it under review. So the board will now receive that at every meeting, and we'll look to review it at 6 months' time to make sure the board are happy with the frequency. In the interim, we're going to keep the organisational risk register coming to board until we feel comfortable that the board assurance framework is delivering the relevant assurance to the board. So I just wanted to confirm that that is where we are, and I'm just looking to seek board approval on the approach that we've got. Thank you, Chair.
Thank you, Callie. Okay, I've got one comment come in. Ian, please.
Yeah, thanks, Emrys, and thanks, Callie. I really like it. By the way, it looks really good, and I think it's easy to see the links of each strategic risk to our strategic goals. So I really like it. I like the icons as well. One little comment on the on page 182, which is the Board Assurance Framework report, the summary, section 1. The column labeled trajectory. Can I suggest that maybe that's clarified, because it's trajectory since when? Because I've had this before in these things. Because is it a trajectory since the last report? Is it a trajectory since the beginning when the risk was identified? Because trajectory can mean many things, and it depends on you know, where. Because I've had this in WISC meetings as well, and their definition of trajectory was since the last meeting. So maybe some clarification on that would help a little bit.
That's a very good point, Ian, and thank you for raising that. And I'll make sure in the finalised BAF that comes to the May meeting, we'll make sure we're clarifying what that trajectory and trend is run from what period. So that's really set out clearly. So thank you for that really good point.
Okay, thank you, Ian, and thank you, Callie. Noting Ian's comments and the responses required, Callie, can I just confirm with board members that we are content to approve this paper, please? Yeah. Okay, then if I could then go on to the next item, please, which is the Clinical Advisory Group Highlights Report. I invite Anna Lewis to present the report, which members have been asked to note.
Thank you, Chair. Hello, everyone. So the advisory group's met twice since the last board meeting. Some of the key themes we've been discussing are around communication, particularly around the changes of services and the involvement of clinicians who are sort of stakeholders for those services, and how we can improve those lines of communication. We also had a very constructive conversation and constructive feedback around the digitalisation of notes and some of the risks and challenges that have been brought up. And we were, again, lucky to have benefited from Stuart Morris's input there, and some of the team from medical records who were able to answer a lot of the concerns that were raised. So that was very beneficial. We did have a discussion around Bridgend and the ongoing sort of feeling of disconnect between the Bridgend locality and what was the old Cwmtaf, and how we can try and make Bridgend feel more of part of Cwmtaf Morgannwg. We know, and it's well recognised, that there are digital challenges, and that is already being addressed. But there were some other challenges highlighted, some areas where Bridgend felt that, again, they were slightly either behind or had some inequities in aspects such as how some clinical policies are being applied, and also provision of some staff resources which are being sort of applied differently in Bridgend to the rest of the health board. Another sort of topic of conversation was around the human aspect of data, and this came up because there was a conversation around performance and data that we get, such as ED weights and ambulance offloads, and the point that that data doesn't reflect the patient story behind that. So a delayed sort of ambulance offload, you know, feels very much like a statistic, whereas the 90-year-old patient who waited 4 hours in an ambulance outside one site
was then transferred to another site where they waited another 6 hours outside that site before they were offloaded. You know, has a very sort of compelling story behind that ambulance transfer delay, and it was quite a useful reminder, I think, for us about what that data means and what the real harm behind data is. But that also applies to clinicians, and I think it's important for us to remember that when we're sort of tired and burnt out, that waiting lists are not just waiting lists. The thing that drives clinicians isn't performance or finance, it's patient stories. That's what motivates us to go the extra mile. But I think we are as guilty of losing sight of those individual patients as perhaps, you know, people looking at statistics and data are. So it's how we all remind ourselves of the patients behind the data that we are provided with. And then lastly, on a patient-centred theme and on a positive note, we had Emily Payne come to talk to us about the Children's Charter. So this is a charter of rights for children and young people, so between the ages of 3 and 25 years old, and it basically supports those individuals at whatever age to have an individual voice and to be treated with respect and to be involved in any decisions made, even if they have a sort of parental legal guardian because they're too young to consent. How we should always be talking to those children, involving those children in decision making. How we need to think about whether we provide the space and resources that children and young people need in order to sort of be able to make those decisions and feel comfortable in our sort of healthcare environment. And this was really positively received by clinicians of all areas, including those of us who just work in adult medicine, because often we see children as the carers of our patients, and it's important then that we're aware of how we communicate with those children. So overall, it was a really positive presentation and very well received. That's it from me. Thanks, Chair.
Thank you very much, Anna, for that report. Can I just invite Dom in, who would like to make a comment, please?
If let me in. First, I just want to thank Anna very much and the CAG group as a whole, because you know, it's those sort of insights that we kind of need, and I think it is lacking really. It's bringing the human voice into this. So I think it's a fantastic role that the CAG is playing. Particularly, you know, your point about data, and every point of data is an individual with a story and a life and a family and loved people around them, and that becomes very easy in meetings when you talk about 67 this and 47 that, to forget that's 47 families who are affected by all these things we do. And I think it's a timely reminder for all of us, and I almost think for every meeting that we come to, we almost need to start with almost that line reminding everyone when we think about it. So I completely echo Anna's point. And the Children's Charter, just want to make a very quick comment on that. Fantastic. Why we haven't had this in place before is a mistake on our part. It's a fantastic thing, wonderful thing to have in place, and exactly the sort of thing that we need to be using CAG for, to flag up and to get implemented on our health board. So that was the only thing I want to make. Thank you, Anna.
Thank you very much, Dom. If I could then invite Carolyn in, please. You're on silent at the moment, Carolyn.
So sorry. Classic mistake, sorry about that. Thank you, Anna, for that report, really, really helpful. I just wanted to get your take on how members of that group feel their voices are heard. Obviously, it comes to us as a board, but sometimes you can get a feeling from people that they raise all this stuff and nothing happens with it. So I just wanted to know what their view was on how the response to these things is managed.
So I'd say we have benefited very much from having quite a lot of input from Paul has been attending a lot of CAG meetings, Dom has been attending, Stuart Morris has attended a lot. So there's a lot of very immediate feedback when staff raise things. They know that obviously I will be bringing those topics to the board, but they also get that immediate feedback. I think the really key thing that we're missing, which I know that Paul and Dom are aware and Georgia are aware that I keep flagging up, is that I think a lot of what we discuss and the feedback that CAG members get would be very well received by the wider clinical body working in the health board. So there are a lot of topics which I think, for example, there are a lot of people working in Bridgend who would feel really positive knowing what is being done to try and improve their digital services and try and integrate them more into the health board, and how important that is to the health board. And we really need wider communication, I think, of the output from CAG, because the CAG members themselves are really benefiting from that feedback. But I think that has a much wider potential benefit.
Okay, thank you very much.
Okay, thank you, Karen. Thank you, Anna. If I could invite Paul in, please.
Thanks, Emrys. Just to follow up on Anna's point there, I think she's absolutely right. I think winding back to remember why I wanted to get this group established, it was very much to have a representative group from across the organisation who could come and put forward perspectives from the front line, but also to enable us to have, as a board and as an executive, a group of clinicians that we could go to talk about particular things that we might be working on. So the strategy, I think, has been a really good example of how Linda and colleagues have come along to talk to Anna about that. Anna's right, though, that the value of it is to make sure, though, that people see that forum is having those conversations, and that also there is progress being made on many of the things that I know, frustrations that come up through that group, which are absolutely understandable. But sometimes, as Anna says, people aren't aware of some of the things that are going on to try and rectify some of the issues. So I've picked up that point, and I'm having some conversations with Lee at the moment about how we make sure that we get an active comms link back to people from that forum. And it may be, I'm just thinking, Anna, you know, things like the staff Q&A that we have corporately, perhaps you or other colleagues from the CAG could come along and we could have one of those focused on feedback from the CAG, for example, so that actually it gives an opportunity to play back to colleagues in the organisation what's going on and the points that are being made. But I think it's been a journey, I think it's fair to say, for many of us, and Anna particularly, and I think a bit of a challenge, dare I say, back to some of our clinicians to say, look, if you want to get if you want to get involved, get involved. There are forums now that you can get involved, and actually we want to try and listen to your views, and actually how do we get those views into the CAG to make sure that people are channeling those thoughts and perspectives back up the line. So I think it's been great progress, but I know fully that we've got still further work to do, but I think we've made a good start.
Okay, thank you, Paul. If I could invite Stuart in, please.
Yeah, thank you, Chair, and thank you, Anna. And actually, just to pick up on your point around regular comms on the digital element, colleagues or independent members will know that at the last Digital and Data Committee last week, actually, we're going to launch a digital blog, a regular digital blog. Actually, it's going to go out either later today or first thing tomorrow, and a regular placeholder in there will be things like Bridgend, and in terms of progress on that. So we've absolutely, you know, I've really valued, certainly coming relatively new into the organisation, really valued to being able to support the CAG group, and we're actually responding with that in that way. So we're going to do a regular sort of digital blog now to hopefully share that information far wider. So thank you for that.
Right, thank you.
Okay. Thank you, Stuart. If I could invite Ian in, please.
Thanks, Emrys, and thanks, Anna. I just wanted to pick up one point that Anna made, and this was in relation to Bridgend again. And I did make a comment in the sidebar, but I think it's worth mentioning because the IMs had a discussion last week about this as well. And I think Bridgend does feel isolated, and maybe something that we as a board need to address. I know we're talking about it, but it's something that needs action, I think. It's not just digital. I think it's in lots of areas that Bridgend feels like that. Because, I mean, Bridgend were on their own, then they were with Swansea Bay, now they were Cwmtaf Morgannwg. And the phrase I've used is they feel like the foster child in the family and they're not part of the family. And I think maybe that's something that needs addressing, and not just in the digital arena.
Okay, thank you for that.
Emrys, can I just come back on that point? I mean,
yeah,
Ian's absolutely right, and it is a theme that does come out not just in the CAG but in other forums that we have and conversations that we have. I think we'll come and talk about the operating model in a bit. I think some of the opportunities we have to try and link things up a bit more through those changes, I think will be helpful in terms of bringing Bridgend alongside colleagues. But I also want to sort of reassure colleagues there are some really good examples of colleagues in Bridgend collaborating and working very effectively with other parts of the system. But I think we are dealing here with some history here of and legacy. But I think we have an opportunity now to try and really look at making sure that we bring things together and we talk as one about the organisation. But we can't deny that some of the logistics and practical things around Bridgend at the minute are different, whether that's digital solutions, whether it's clinical support they may receive from Swansea or other places. But we are working through a whole programme of disaggregation still, which we are very keen to expedite to sort out, and to be fair, as are Swansea Bay as well, because they recognise that 3 years on there are still a lot of legacy things that they're having to deal with Bridgend that they want to also finalise. So I think there is a programme of work, and again, it's another topic that we need to make sure people know that we are working on some of these things, because sometimes people don't realise that there is work going on behind the scenes to try and rectify some of the challenges they have. But it's a fair point that Ian's made, and I think we need to be really mindful of it moving forward.
Okay. Thank you for that, Paul. There is no further comments there, Anna, but can I just say thank you very much for the hard work you've been doing within the clinical advisory group. And it's, as I've noted from Dom, it's a journey to get where we are today, and it's recognising the hard work you've done, and certainly the pertinent points have been raised in today's board. It's created a lot of debate about, some of the things that what's coming up through the CAG group, and the benefits of how we can deliver some outcomes in respect of that. So thank you very much.
Thank you, Chair.
I am conscious that I missed an agenda item earlier to 5.3. So if I could just go back to 5.3, please. And this is the annual board effectiveness self-assessment for 2021. And I'd like to invite Callie Hamblin to present the report, which members have been asked to approve. Callie.
Thank you, Chair. Like I said, the board members have already received this self-assessment offline to comment and consider in terms of our maturity rating. It's a requirement of our standing orders to undertake an annual board self-assessment. And the way we've done it in the last couple of years is tried to take into account all the sources of assurance that we've gathered through the year, whether that's internal sources of assurance that we've done ourselves, or whether external sources of assurance from internal audit or Audit Wales. So that's pulled together in the papers, which I don't intend to go through because I'm taking them as read. So throughout the consultation that ran through February and March, the consensus from board members is that they agreed a level 4 maturity in terms of our assessment. And level 4 is defined as that we have well developed plans and processes and can demonstrate sustainable development and improvement throughout the service. So that's what a level 4 is defined as. So really I'm presenting it to the board today to seek their approval that they agree with that self-assessment score, and we will then include that in our annual report as part of our governance statement. So just really seeking the board approval, Chair. Thank you.
Okay, thank you, Callie. George, would you like to come in?
Yeah, just very briefly, thank you, Emrys, and thank you, Callie, for pulling all of this together. I suppose the comment I would just make to the board is that this ties very nicely and mirrors exactly where we are in relation to the journey of improvement under targeted intervention. So we've got the quality and governance domain, and it all reflects a lot of the work that's been going on there. So it's just an added layer that hopefully the board will see as running very clear and alongside all of that improvement work. So I just wanted to make that clear. Thank you, Chair.
Okay, thank you, George. And there's no further comments or questions. So can I confirm through the board that you're happy to approve the annual board effectiveness self-assessment for 2021, please? Okay, that's been approved. If I could then go on to item 5.5, please, which is the COVID-19 inquiry preparedness to include the Charter for Families Bereaved through Public Tragedy. I invite Georgina Glathley to present the report which members have been asked to approve. So, George.
Thank you, Chair. So at the point of writing this report, we hadn't received the draft terms of reference, which obviously had the inquiry team have now issued draft terms of reference. So it's been helpful to see the breadth and scale of the UK inquiry. It also supports, actually, in our view as an organisation, that there would be little requirement for a Wales inquiry, but I am aware there is still some pressure to do a Wales inquiry as well. So the papers in front of you do set out our preparedness as an organisation to respond to the inquiry, not just from an evidence perspective, but also potentially from staff being called to as witnesses in the inquiry. So that will include past staff as well as current staff. So there's an element of our preparedness around supporting the well-being of staff who may be called as part of the inquiry. Just to be clear, we are planning for a worst case scenario, as it were, in sense of making sure that we are fully prepared to be fully involved in the inquiry should we be called. But I'm pleased to say that we are working across Wales in relation to Welsh Government as well to make sure that we reduce duplication, share best practice, work collectively as NHS Wales as well. The only other development I wanted to report also was the chief executives at their leadership board supported a paper earlier this week to pull together a all Wales working group to make sure that NHS Wales works collaboratively in response to this. So until the final terms of reference are issued and core participants named, we are still planning a very robust response to this inquiry, and it's here for your noting today, but also you've already identified that there is a charter for families bereaved through public tragedy that we're asking the board to adopt. This was developed in response to the Hillsborough disaster, but we, as all organisations in NHS Wales, are encouraged to adopt this charter so that we link in with families and treat families with the utmost respect during all of the inquiry preparedness and response phase. I'm happy to take any questions or comments, but hopefully you'll provide you with some information in the attached report. Thank you, Chair.
Okay, thank you, George. If I could invite Paul in, please.
Yeah, thanks, Emerson. And as George said, we talked about this at the NHS Wales Leadership Board this week, and I think there was a clear steer really from Judith that the expectation is that it's unlikely that individual organisations will be called, with some exceptions. For example, Public Health Wales clearly are going to probably be very much front and centre of some of the conversations. I think it's right that we've got the right preparations in place for ourselves, but balancing that, I guess, against the expectation that given this will be a UK-wide inquiry, that there is going to be some coordination, I think, within Wales of how we best respond. So I think good that we're fully engaged in the national conversation. I think the Confed are also going to help sort of coordinate some of these things and responses. So yeah, just I fully support it and agree that we should adopt the charter as well that's proposed.
Thank you, Paul. There are no further questions or comments in respect to this, so can I confirm through the board that you are excuse me, happy to approve the work that's been undertaken here, please? Yes, okay. If I could then go on to item 5.6, please, which is the Planning, Performance and Finance Committee highlight report. I'd like to invite Mel Jahu to present the report, which members have been asked to note.
Thank you, Chair. I'll make it very brief because I know it's a busy agenda. You'll see the highlights in front of you. The one that I'll pick up, we looked at many issues on the 22nd of February at the Performance Planning and Finance Committee. And the one issue that we thought was important to highlight and escalate to board was the issue relating to the level of underlying deficit that was identified by our Director of Finance, Sally May, in concern of the challenges ahead, which was a deficit of around about 44.5 million. And we felt this was a significant issue that needed to be brought to the attention of board today in relation to the challenges that we're going to be facing during the course of the next financial and performance year. But I'm conscious that we'll have an update from the Director of Finance later on in this, so there might be a more up-to-date situation that the Director of Finance, Sally May, can bring to our attention. Other issues that we looked at, of course, were the issues that we always look at during the course of PPNF, that's planning, performance and finance, are the issues of the development and the progress of the integrated medium-term plan, the performance dashboard in relation to all areas covered by performance of the Health Board, and those issues are covered within that report that I've submitted to you today. Thank you, Chair. If there are any questions.
Okay, thank you, Mel. Are there any questions or comments to make for Mel, please? No? Okay, thank you for that, Mel. If I could then go on to item 5.7, please, which is the Digital and Data Committee Highlights Report. I invite Ian Wells to present the report, which members have been asked to note.
Yeah, thanks, Emrys. Just as Mel did, I'll pick out the highlights from the report, but I'm happy to take any questions if people wish. The two main items which we were asked to escalate to at board level were, first of all, the ICT services and the disaggregation from Swansea Bay. In other words, the Bridgend issue, which we also mentioned earlier on. So that was identified as a key risk regarding funding pressures in that area. And I would note as well that we've recently had an internal audit in that area as well, and we've had limited assurance on that. I would add, however, that the team are making huge efforts to move to make that situation better. So I've got quite a lot of confidence in the team in the direction they move in with regard to that. The other item, which has also been escalated, is in the areas of the failure to deliver a robust and sustainable information governance function. And this was to do with the data protection impact assessment, the DPIAs. That has now been escalated onto our risk register. But once again, happy to take any questions on that if people wish. It's primarily due to the large amount of requests that we are getting in as an organisation at the moment, and some work has been done on that. That is not, we think, going to go down, and so that continued high level of work is going to present us an ongoing risk. So those are two things that I mainly wanted to mention. I'll just briefly comment on the huge amount of work taking place as well on the IMTP, the digital programme related to that, and the very consistent and logical method that the team are using in order to take that forward. So I would commend them in terms of that as well. Other items are there in the report, but once again, happy to take any questions if people wish to ask them. Thank you.
Thank you very much, Ian. Are there any comments or questions to Ian, please? Okay, there are no comments or questions there, Ian, so thank you again for the report. Can I now propose that we take a break for and come back at 11:15, if that's okay with colleagues? Thank you. Okay, welcome back to today's board meeting. If I could then go on to item 6, which is delivering our purpose and strategic direction. And on 6.1, if I could refer to the quality dashboard, please. And I invite Greg Dix, Dom Herford, and Georgina Galately to present the report, which members have been asked to note. Greg.
Thank you very much. Thank you very much, Chair. I'll kick off first, and then George and Dom will come in following me. So just a few key areas to note in this report, and to help board members, we've set out a summary on page 2 and page 3, because I'm mindful the report is 11 pages long. The improvement work around community pressure ulcers has commenced with earnest now, and we had a recent quality and safety committee a couple of weeks ago where the detail of this programme was presented. You recall that had some anxieties around the numbers of pressure ulcers of patients being admitted to our EDs and under our DN workload. The programme has been supported by ICTM and also WIC, the Welsh Wound Innovation Centre, so we're very grateful for the support from WIC. So a real collaborative approach to this improvement, and a methodology will continue going forward. The outcomes of this improvement programme in terms of measurement strategy, trajectories, etc., will continue to be tracked through quality and safety, and then in this current report here. Just to pick up incidents, if I may, we've recently received some benchmarking information from the DU delivery unit in relation to our numbers of incidents reported per 100,000 population, and we align to the other health boards across Wales, certainly from a nationally reported incident perspective, so under kind of the old money, serious incidents, so it's very reassuring to hear that. Our key themes regrettably remain as previous reports, with access and delays continue to feature very highly across most of our specialties. And we're really hoping that as the elective recovery work adds some pace, that then we'll start to see a downward trend in relation to some of the incidents related to access and delays. Whilst I'm on incidents, Chair, tomorrow actually, the 1st of April, is the go live date for our new incident module as part of the All Wales new DATEC system. So we've already successfully implemented several different other modules. We have been working through our transition plan for some time. Whilst the majority of risks have been mitigated, we will for a period of time be running 2 systems, so the old DATEC system and the new DATEC system, until we transfer all of the legacy incidents to the new system. The team will put in place checks and balances along the way, but we could potentially run a risk of double reporting as we progress, but we'll make sure that information, clearly that goes to committees and board, will be as validated as it can be. We have clearly raised concerns to the National Programme Board, and which have been accepted, and by all accounts it's going to be a risk across Wales, but nevertheless I'm feeling a little bit anxious around that, but we'll track it through our own internal governance. That was it from my perspective, and Chair, if it's okay to hand over to Dom and to George and then take questions following that. So thank you very much. Thank you.
Okay. Thank you, Greg.
I'll go next if that's all right then. So I'm going to present the 2 parts to you, which is the medication instance and our mortality rates. So as we've seen from the pack that's included with this, that we have had 67 individuals who've had medication errors and instance over the last month. This is actually a decline on previous months, and we are below average for both of those. That doesn't help the individuals particularly involved, but it does show a trend that we are improving on our areas here. I'd like to point out that none of the medication errors resulted in any severe harm or death. 47 of the 67 actually had no harm whatsoever to them. The remaining people obviously had all aspects investigated and explained to them as to what happened and why, and what we were putting in place to stop that happening again. A lot of this is been done, this decline that's been sort of seen by the trend here, also underneath our average normal. It's been a huge effort by our ward pharmacists, working very hard at making sure that the medication errors are prescribing is accurate, and any concerns flagging that up with individuals particularly. Administration errors, again, we have seen this as a trend that we think is probably common across other areas, that while people are very stressed, they make more mistakes, and you can almost mirror the medication errors here against the rates of COVID. Now, I'm not making that as an excuse, but you can see as the staff are under stress from working outside their normal environments, that's when medication errors occur. So that also shows an improvement on there. We are going to start looking at changing this data. Instead of giving you the monthly numbers, we're going to look at it as medication incidents per 1,000 bed days. That'll make it much more user-friendly and easier to understand of what the actual numbers involved are. The next one I just want to bring to your attention is the mortality rates, and as would be expected, by looking at these, you can see exactly they map the pandemic waves that we have had. We've been now around our usual average, which is we will never get mortality to zero in an acute hospital setting. That's not the nature of what we do, but normally keeping it around about this number is what would be accepted as normal for a health board. This time, I think you'll notice, though, that there is no significant rise on the third wave that we had, which started sort of August, went into December. Actually, mortality stayed very, very low during that time, and that again fits with what we know from the Omicron and the Delta viruses, that we have far fewer mortalities related to that significant illnesses. Again, that's all due in nature to the vaccination programme, as well as the actual mutation of the virus itself. So work to be done. But there are improving, and we are getting ourselves back on track in these areas. I'll happy to take some comments or questions at the end, but I'll hang it to George for the rest of the presentation for now.
Okay, thank you, Dom. George?
Thank you, Chair. So I'm just going to focus on the concerns element of the report. Unfortunately, I am presenting a report with a deterioration in our response rates down to a 24-month low of 47%. So just to remind board colleagues, we aim for a 75% response rate within 30 days of receiving a complaint. So just to reiterate, we're on 47 in February. The reasons for that are primarily redeployment of our clinical staff who would ordinarily be investigating and responding to complaints. They were redeployed, if you recall, January to respond to the increased efforts for the vaccination programme, which has had a direct impact on the capability and capacity, really, of people to be able to respond within the organisation to concerns. So it's an understandable dip. We are struggling to get that back up, I will be honest. You will recall that we had an internal audit review into concerns tail end of last year that has led to an improvement programme in response to the recommendations from that report. And we are we're doing a pilot of triaging complaints that hopefully will help support a new system moving forward. But lots of effort going into this to get us back onto track, improve the flow of and response rates for concerns within the organisation. Again, as Greg and Dom have invited comments or questions, happy to hand over. Thank you.
Okay, thank you, George. Are there any comments or questions for Greg, Dom or George, please? Yeah, Jane?
Thank you, Chair, and thank you all for presenting this report. I just wanted to assure board that all these issues were considered in depth at the recent quality and safety meeting, and indeed there was a lot of scrutiny of these particular issues. We're going to have a highlight report on the falls issue at the next quality and safety meeting. My comment or question really is around the complaints, George. You're absolutely right to highlight the fall off in dealing with complaints. When will we see any improvement in this? I mean, one of the things that we do have to do is address issues and learn from issues. Are we likely to see an improvement by the time we meet again as a board?
Yes, is the short answer to that. We are already improving. We just need to keep pace at that and take the reflective lessons from the pilot that we're running around implementing a new process. It will require a little bit of changes to how we log, manage and interact across the health board in response to concerns. So it will require a little bit of change, but we will reflect on the pilot and make sure that the lessons learned from that build into a much stronger process. Plus the implementation of those recommendations from the internal audit are already underway. So, and as you've already alluded to, Jane, the Quality and Safety Committee will be having a thorough update on response to those two audits, the internal audit on concerns and the Welsh Risk Pool review into claims at the next meeting. So, so yes, in short, yes, we would like to be confident that we will see an improvement in that response rate.
Thank you, George.
Could I come in on that as well? Just briefly.
Sure. Okay, Dom.
Just to sort of say that, you know, George presented that part of it, but it's very much Greg and myself and George working together on this, and Lauren as the Director of Therapies. You know, there's a huge amount of learning across the health board that we're not quite joining up enough yet. We know what needs to be done, and when that learning themes get in place, that will show the improvements that we're looking for here. So it's a work in progress, but we are getting there.
Thank you, Dom. Jim?
Thank you, Chair. A question and some comments, if I might, please. In relation to the comments, I visited Ward 9 yesterday, and I was intrigued to see the sort of patient monitoring going on from the sort of main reception desk. And I was advised by the nursing team there that has actually helped to better understand the impact of patient falls, where they're not really falls, they've been more collapses, and it's actually highlighted an underlying health problem. And I'm just wondering whether the reduction in falls in February is linked to that better understanding of the patient's health condition. If I may finish my sort of comments and then I'll pass off. I'm pleased with the way in which the new report is being presented, because it gives me the opportunity to see the sort of trend data, but the new initiatives such as benchmarking and KPIs to look at the number of falls, for example, per bed day, and standardising across the whole board area will actually improve my scrutiny and understanding.
Okay.
Shall I come in there, Chair?
Yes, please.
Jim, I would love to say yes, but I think it's just normal variation in relation to the reduction of falls in February, which is obviously plotted on this SPC chart we've got in front of us. That said, all of the great work that Regend POW did on falls reduction pre-COVID has been, and clearly when they were part of Swansea Health Board prior to that, is now being shared across all of the CTM, being led very ably by Debbie, my deputy, who's got significant experience with leading falls reduction programs with specific links in each site. But thank you for your question.
Thank you, Greg. If I can invite Paul in, please.
Thanks, Emrys. Yeah, just back on the complaints point, I think, as George said, I think there is still quite a bit of work to do. And I'd also say to colleagues that the opportunity as we start to again bring some of the functions together across the three localities does also give us the opportunity to streamline the process, because I think to be honest, part of the challenge we've had over the past couple of years is slightly different ways of reviewing complaints that come through from different places in our area, in our health board, and so there is an opportunity to standardise that. I think also we need to perhaps think about what are complaints, actual complaints, and what are people making inquiries about things or making comments about services that in other areas you would deal through a PALS route. So we have an inconsistent PALS system across CTM, and I think, to be honest, we're probably putting quite a few things through formal complaints and all the associated process that goes with that, when actually we could probably reach pretty quick resolution through a sort of more proactive PALS approach of actually just talking to the patient or their family member straight away, dealing with the issue that they're concerned about, and probably closing it down to their satisfaction there and then, so that actually the number of complaints that come through are then actually formal proper complaints that do. And it would just mean for our clinical staff, they're not then bombarded with lots of different sort of bits of requests for information, because I'm very conscious for many of our colleagues that takes quite a bit of their time. So I think there's something here about how we can look at that, and as we start to look at how we interact with our population more broadly, I think there is, Stuart Morris and I have had some chats about, you know, opportunities to think about how we centralise patient contact in one place to actually bring some consistency of approach across the patch. I think that will also help us in our response. And also, I just thought, George, and I think this might be planned, but there's something, isn't there, about it's not just about the complaints as a process, it's also about the tone of how we write letters. And you know, to be completely honest, some of our communication can still sound quite bureaucratic and formulaic, and I think there's something about also we shouldn't miss the opportunity as we review the process to also take the opportunity to review the tone of the correspondence, and it may be that we could work with some colleagues such as CHC or patient groups, or indeed, you know, people who are used to in other industries dealing with customer contact, to perhaps think about some of our letters, because as someone who signs quite a lot of them off, I do sometimes slightly bulk at some of the terminology and get my red pen out, because it sometimes can just feel very formulaic, shall we say, in terms of how we've responded, and we could probably put a more friendly tone in some of the communication.
Thank you, Paul. George, you want to respond to that?
Yeah, so thank you, Paul. And yeah, just I haven't gone into a significant amount of detail, but the improvement plan for concerns does include training on communication and customer care, for want of a better phrase. So yes, all of the quality of our responses is being looked at. We're going to really look at some of those consistency issues that you've touched on. So yes, there's a whole heap of work that is planned that will hopefully not just improve the process but improve the quality as well, and our interactions with our patients. Thank you.
Thank you. Are there any other questions or comments for Greg, George, or Dom? No? Can I just ask one last question then to Greg, if that's okay? I know in your report, Greg, you made mention of the number of people coming in with pressure areas from the community. Is there anything that we need to be particularly aware of from a community perspective as to why people might be coming in with pressure areas?
Yeah, of course. Yeah, great question. So a few things spring to mind that I'm aware of. The first is some of our patients that are under a district nurse caseload require more education in relation to relieving their own pressure areas when the district nurses aren't there. So certainly support from carers we're working on as well, to encourage patients in their own homes to support themselves from a pressure relieving perspective. So that's one issue that we're addressing through the improvement programme. The second was in relation to, you know, sadly during COVID, some of our patients were receiving a less number of visits in relation to risk stratification and prioritisation, which again could have been contributory to some of our patients coming in with, certainly with some of the lower grade pressure ulcers, so grade 1 and grade 2. And the third thing is in relation to patients coming in from care homes or residential homes. So our CHC, so our continuing healthcare nurse assessors are working with care homes in that regard, and you'll recall that one of our advanced nurse practitioners who happened to win one of the RCN Nurse of the Year awards last year is equally leading some improvement work with some of the local care homes. So I think there are several things, Chair, which are driving the numbers coming through the front doors, and I am confident that the new approach, through improvement methodology with the support from partners, will really start to reduce the numbers coming in, like I said, which will be governed through quality and safety going forward.
Okay, thank you for that, Greg. Okay, there are no further comments or questions. Could I then move on to the next item, please, which is 6.2, and it's the Integrated Performance Dashboard. I invite Linda Prosser to present the report, which members have been asked to discuss and note, please.
Thank you, Chair. I'm going to, as you know, the report that we present here is the integrated report. So the first section of it is the quality report, which you've just had. So I'll move straight down to what is page 13 of the. Actually, I won't. I'll move down to page 12 of the report, because it's a difficult report to read again. There's slight improvements in some of our elective indicators, but not as much as we'd like. And I think the chart on page 12 around our sickness absence rates sits alongside Paul Mears's comment earlier about the demands that we're seeing, not just in Cwmtaf Morgannwg, but across the country for urgent care at the moment. And these two issues of high urgent care demand and high levels of staff sickness are conspiring to make our recovery really difficult. So some green shoots, but not where we want to be. I will just note on page 13 some of the actions there that have been undertaken vis-a-vis patient care and flow in the urgent care system. Not least, there was a 2-week kind of reset exercise at the beginning of March, which really provided a lot of focus on the processing of people through hospitals, and actually has resulted in discharge hubs being established, and those being continued with health and social care staff working side by side to expedite discharges. And as you can see, activities in the EDs to try and treat people in an appropriate manner and perhaps redirect as appropriate. So unfortunately, the situation still has an impact on our stroke indicators, and where we win some and then we lose that benefit. So I know that the team are working really hard to make sure that patients get directed to the right hospital in the first instance if they need thrombolysis. And I know that there's a lot of work going on to try and maintain the discharge of patients so that we've got capacity for new stroke patients. I was just going to touch on the slide which is page 15, the chart across the top. You'll see there that this is the number of inpatient and day case interventions that we're doing, and you'll see there through January and February that we're really struggling to get back up even to where we were last summer, but it's very much about those sickness rates that we have at the moment. But the fact that we are where we are has seen some improvements in numbers of people waiting for more than 52 or 36 weeks. And so then the picture in cancer is similar, some improvements, but still not. And I know that Gareth and the ILGs have been working really hard on the cancer pathways, so we are seeing some improvements there. I just wanted to also highlight the big weights that we've got. So I'm now on page 19, the big weights that we've got around diagnostics, which are we are out of kilter with our Welsh colleagues on our diagnostic delays in particular. So, and that's the reason why there are some specific initiatives being undertaken. As you know, there's a a mobile endoscopy unit being commissioned at the moment to work on some of that backlog. I understand that the commissioning of that is at the moment working through some issues around airflow and potential Legionellas risk. So there's still a bit of work to do there to bring that one online, but we're confident that the supplier is working at pace on that. So I think the rest of it speaks for itself in terms of the impact on the numbers, and we've probably pulled out most of the highlights. I mean, it goes without saying that the pressures on our emergency care system sadly do result in ambulance waits, and we've heard earlier about concerns about the impact of that on patients. Although I would say that I think the staff do a great job at ensuring the welfare of patients that are waiting in ambulances, and part of our work with the Ambulance Trust has got to be making sure that we supply alternative care pathways for as many people as we can, because we do have more patients brought into EDs through on ambulances, certainly than I'm used to, as a proportion of those that call. So we've really got some work to do there. So I'll pause there, Chair, because I'm sure there will be some specific questions.
Okay, thank you for that, Linda. If I could invite Paul in, please.
Thanks, Emma. So a couple of points from me, I guess. This is a really challenging picture in terms of our performance where we are operating at the moment, and as Linda's highlighted, this is a common set of challenges that many other health boards across Wales or indeed across the UK are all dealing with. Having said that, I think there are things that we can focus on improving ourselves as well. So the point about diagnostics, I think, is really important, because diagnostics, as we know, are massively important for our cancer patients as much as they are our planned surgical patients as well. So I think we do need to look at that quite carefully, and we are, as Linda said, doing quite a bit of work on that with endoscopy capacity that's being brought on stream, which will certainly help. And we're also actively in conversation with Anara and Bevan and Cardiff and Vale about looking at a development of community diagnostic centres model for taking non-urgent scanning out of the DGH sites and trying to establish an alternative provision in the community in conjunction with independent sector partners. So I think that again is something we would hope during the course of this coming financial year we'll be able to start to get on with. But I think it is a big challenge, and the other area of diagnostics which I think is really important to flag is pathology as well, because pathology sits very much at the core of many of our procedures, whether they're emergency or elective. And we know that we have some significant challenges in pathology as well. There are a number of conversations going on with colleagues in pathology at the moment, and Fiona and Mel Barker and her team are doing some work with our pathology teams to look at how we can work again in a more joined up way with neighbours around pathology, because it is a service that does lend itself to looking at opportunities for working in a more joined up way across a region. And I know there have been several attempts at this over a number of years, but I think given the current pressures we're under, and particularly the workforce challenges we have in pathology in terms of finding consultants, even if we had more than enough money, we probably would struggle to find the staff. So we are going to have to think of a different way of approaching that problem. So I think we talk a lot, don't we, about orthopedics and ophthalmology, and clearly those are all really important things that we need to focus on. But I think that we really do need to make sure the diagnostics element is front and centre of our considerations, because if we don't get that right, we can do all the things we want around operating and other things, but we won't get the people into that place where they can be ready for their surgery if they've not had the right diagnostic test before. So big opportunities, I think, for us to improve on that.
Thank you, Paul, and it's really positive to note the work that we're looking to do with our partners as well, our fellow health boards in the region. Can I then invite Nicola in, please?
Thank you, Chair. Thank you, Linda. Linda, I just wanted to pick up on an issue I know I've raised several times in PP&F and Q&S, and that's our compliance with sepsis, which is on page 5. And I know that in January Q&S we received an improvement plan which acknowledged sepsis as being a leading cause of acute deterioration, but in September 21 in ED compliance was 61.5%, and in October 21 inpatients was 100%. And I know we have a plan in place with a trial period up until the end of March and a review in April, but in the current table we have there, we have a 16.7% compliance with sepsis 6 in ED. I don't know about anybody else, but I find that really alarming. So I just wondered, has anybody got some feedback as to, you know, we've got an improvement plan, but our compliance is deteriorating with an improvement plan. So where are we going from here to make a difference?
On that question, shall I invite Dom in to comment on this, please?
Oh, thank you, Chair, for that. Nicola, yeah, no, I know we've spoken about this as well. And I'm just completing a report at the moment. I've only got vague outlines at the moment. I'm going to get a bit more detail as to what the actual causes are and where the problems are and which part of sepsis it is that we're actually not meeting. We do have a number of incidents on it. We know that the target is mainly in our EDs. And I'm not being critical of our ED staff, that they know that and they accept that problem's there. And we had one major problem in the Prince Charles ED, which came up in the improvement work. They've now introduced a way of tackling and training their colleagues, and actually that data on that site has actually improved significantly. So the radar committee are looking exactly at that and replicating that on the other 2 ED sites. But it's not just ED, we need to be looking at this sort of broadly and what the themes are and working on that there. So what I'm going to do, as soon as I have this full report, I mentioned and talked about it at the Quality and Safety Committee. As soon as I have the full report as to what the causes are, I will bring that to the Quality and Safety Committee to explain what action we are doing and to have a targeted approach to actually deal with that 16% and drive that right up to 100%.
Just quickly come back, Chair, please.
Yes, sure.
Thanks, Dom. You know, and I will appreciate to see the plan, but I do think we need to have some timescales, because I feel like we've been discussing this issue now, but it must be coming up to a 12-month, and the situation is just deteriorating. So it would be great if we can have some targeted timescales as to when we're going to see some improvements.
Absolutely, absolutely. I'm not going to make numbers off the top of my head now and promise you something that I can't deliver, but you can give me a couple of weeks. I will get back to that. I will certainly have the full report of what our instances by the next Quality and Safety Committee, and by that time I would hoping that our the radar teams will be actually on the other 2 sites and actually delivering the training that we needed. I'm not going to give you a definite time now, but I will give you one very soon, Nicola.
Thank you.
Okay, is that okay with you, Nicola? We've got a time plan that will be presented to us at a future date. Okay, can I invite Jim in, please?
Thank you, Chair. Linda, that's a very challenging report to read, but I appreciate the candour and the efforts being made to address the challenges we face. My question relates to slide 15 in relation to the outsourced activity table. I'm not quite sure that I understand the comments. The chart refers to patients sent and returned to Spire and Nuffield. I don't understand what we mean by returned. Is that return post-treatment or return for corrective treatment, or what? And the second question, if I might, is relates to the agreed capacity that we've when we've outsourced to those institutions. That there was an agreed capacity of just over 1,400 cases, but they've actually treated 800. So are we paying for a service that hasn't been delivered, or are these self-paying or medically insured cases?
Thank you, Jim. So I can answer the first question straight up. So we send the details of a range of patients that we think might be suitable for Nuffield or Spire treatment. They then review those, and if they feel that they don't have the facilities or the staff to handle those people when they've looked at the detail, they send them back. So they are being sent back untreated and they return to our waiting list. I see that Gareth's here, and he might know the answer to the financial question, which I'm not close enough to answer.
No, and Linda, that return issue is spot on. It's often to do with the complexity of the patients. Our colleagues in the private sector, for I think legitimate clinical reasons, generally prefer the more simple cases without complications for the obvious reasons around intensive care and the risk of deterioration. So that's a legitimate thing for that to be in place and as part of contractual arrangements with their private providers. In terms of the payment, we originally agreed as part of our plan for 21-22 to have 2,800 procedures outsourced, with the reduced capacity available within the private sector as other people are accessing it through insurance and pay-as-you-go arrangements. That 2,800 capacity wasn't available to us through the year, so we've been able to access the capacity that is possible within that constrained capacity, and we only pay for the patients that go. So we pay on a patient cost per patient basis.
Thank you both.
Okay, thank you, Gareth. Thank you, Linda. If I can then invite in Linda, please.
Thank you, Emrys. Hi, Linda. Accepting that this is a report about a million different things, I wanted to pick up the issue on endoscopy and pathology, if I could. Obviously, we're quite excited about the opening of the new endoscopy unit, so hopefully that will get up and running soon. But I wondered if you could explain, is the capacity for that endoscopy unit going to solve the problem? If not, is it the tip of the iceberg in terms of, yes, it'll take a small percentage, or will it take the bulk of what the issue is going to be? Because I wasn't clear about that. And then the other point I just wanted to pick up on was Paul's point on pathology, and my understanding from a workforce perspective is that pathology situation isn't going to get any better because people can see what's coming down the track, therefore not choosing to go into that profession now. And I accept that we're going to look at the situation with neighbours, but Paul, I wondered if there was any digital acceleration we could use on any of this, actually, given the quite burning platform around this, to see if there was anything digitally we might be able to do to help with that.
Shall I come in, myself?
Yes, please, Paul.
Yeah, so yes, Linda, you're right. I mean, key opportunity with pathology is the move to digital pathology, which enables obviously samples to be shared very easily between sites and clinicians. In fact, it doesn't even have to be locally, it could be across the UK, which does bring about a whole new opportunity of workforce and indeed recruitment opportunities for people who might not necessarily be able to relocate to South Wales. There is a piece of work going on across Wales looking at deployment of digital pathology. I think I need to caveat though, saying that it has a substantial price tag associated with it, and at the minute I'm not quite sure, with the capital constraints and pressures there are across the NHS in Wales, how easy it will be to resource that. But I do think it is something we need to really push hard for, because I don't see how we're going to be able to modernise our pathology services in Wales without that, because it's becoming commonplace in other specialties, in other areas across the UK, and in fact, you know, if you look at what's gone on in radiology, you know, every radiology service now uses electronic imaging, and I think in a few years' time it'll be the same in pathology. So we don't want to be not able to provide that. So it is a real challenge. But you're right, that provides a big opportunity for us to share more effectively our capacity with neighbours. And just on the point about endoscopy, it won't solve the problem completely. It will help make an inroad into the pressure, but there is also work going on across the southeast to look at how we work with Cardiff and Vale and Anara and Bevan on endoscopy capacity. Each of the health boards individually have plans to try and increase incremental capacity now. So across our 3 health boards, there's an additional 5 endoscopy theatres being brought on stream over the next year to 18 months. That still is going to leave a gap. I mentioned earlier the conversation about regional diagnostic centres. They potentially have the opportunity to also put more capacity into endoscopy. But I think the solution for bridging that remaining gap is going to be looking at how we work collaboratively with our neighbours, and that's where we've got a South East Regional Endoscopy Group now established to look at the demand and capacity plans across the 3 organisations, and to help come up with solutions between our 3 of us on how we can bridge that gap, because it is a significant challenge for everybody to try and deal with individually. And again, the workforce is another key limiting factor you know, we could build more capacity, but if we haven't got the workforce to staff it, it's not going to really deliver for us. So we need to think also about a longer term plan, which is being led through HEIW, on how we grow the endoscopy workforce, both in terms of consultants, but also nurse endoscopists that we need to train up.
Okay, thank you, Paul.
I think Gareth might just want to come in.
And Gareth, did you want to come in, please?
Yeah, it's just an additional level of detail on the endoscopy side of things for Linda. So the endoscopy unit does get us to a position where our run rate of capacity is above our new demand coming in. So it allows us to start eating through the backlog, which puts us in a really good position. But it's not sustainable, obviously, with the very terminology here, with it being mobile. We have when we commissioned it, we had something like 7,500 patients on our backlog, both surveillance, urgent routines and so on. The mobile unit gives us about 4,000 patient capacity through a year, so it's a big step forward, but obviously it's time limited, and the regional solution, as Paul described, is the route forward. But it is really positive to be in a position where finally our capacity will be above our demand, with immediate effect.
Thank you, Gareth. You okay with that, Linda? Yep. Okay, if then I can invite Jane in, please.
Thank you, Chair. A comment and then a question. I really welcome Paul's comments on focus on pathology in particular. I visited the RGH department this week, and it's very clear the pressure the service is under. Also wanted to bring out something which I hadn't appreciated. Obviously, we can see the raw numbers of cases that are affected. What we can't see is the complexity of those cases. The delay in presentation caused by the pandemic means that pathology is actually having to deal with much more complex cases, and every one of those is actually taking probably 5 times as long as they would have if there had been a timely presentation. So the position is even more serious in my view than the raw numbers would indicate. My question actually relates to page 25 and to delayed transfers of care, where the graph at the top of the page shows our performance compared with the All Wales average. And it's very clear that we have a significant problem and that it is actually escalating. Be interested to know what we can do about that problem. Obviously, it involves working with our local authority partners in particular in terms of making sure that we can improve the flow.
Yes, I can comment on that. You'll see from the reasons for delay is that the larger part of that growth is for people who are waiting for care packages in their own home, and this really relates. And you can see, I have to say that it really started to escalate in January. So you can really link that to the workforce, and particularly interestingly in Bridgend, they're really struggling their care agencies are really struggling to recruit home care workers. We are working with the local authority on ways of attracting people into health and social care through joint initiatives, but then frankly the numbers are low to start with as we test and initiate things, and I have to say that, you know, it is an ongoing worry, and of course there's people in the community also waiting for home care who, whilst they're waiting, become at risk of admission, and I know that the local authority are having to balance that quite carefully. Again, we are working with them to combine our workforces as much as possible and combine our efforts, but against that backdrop, it has been quite a difficult position.
Do you think we're likely to see improvement in the coming months, Linda?
I fear that it might be slow. It will improve. I don't know that we're going to clear that in the next few months. We need to be in a better place by next winter. That's definite.
Can I just follow on from that, Emrys? I mean,
yeah,
just
sure,
to support what Linda said, and Lisa's obviously on the call as one of our key colleagues in terms of social services, but there's a lot of work going on with colleagues in social care. I think we had a very helpful conversation last night with the RCT about some things we're going to try and do in the short term to alleviate some of the pressure. There isn't a quick fix to any of this because it is systemic in terms of workforce challenges that we're all facing across health and social care. I saw, and Linda's just put another comment in there, some of the feedback we picked up at YCR last week with people who are waiting for adaptations in their homes, causing a significant challenge. So I think there are some short-term things we can try and work on jointly with the council colleagues together, but I think there's also something about a bigger piece of work we need to do about how we bring more of our services together, look at how we can share resources more effectively between health and social care, and that's certainly part of the conversations that Emrys and I have been having with the leaders and chief execs over the past couple of months. And we've just got a programme at the moment. Last week, for example, the leader and chief exec of RCT Council went down to RGH to talk to the teams there about some of the impact of pressures on them. Next week, the leader and chief exec and director of social services in Bridgend are spending some time at POW talking to the teams, and we're arranging similarly for colleagues from Merthyr to go and spend time at PCH. I think because I just think it's important that everyone understands each other's challenges and tries to work out what we can do together to try and resolve the issues. So I think there's definitely really positive engagement with our social services colleagues to try and solve the solutions, and I think we need to work actively to try and resolve it, because as Linda said, we want to be in a better place before next winter to try and things that we can do more quickly. We want to get them in place now, whilst recognising some of these issues are systemic and let's be honest, are not unique to us in South Wales. Indeed, Wales, or indeed the whole of the UK is dealing with similar pressures. But I think there's great opportunity for us to take that forward.
Okay, thank you for that, Paul. Did you want to come back on that at all, Jane?
No, I'm really pleased to hear that we're taking a whole system approach rather than simply trying to solve it ourselves, because there's no way we could. Thank you.
Thank you, Jane. And I suppose the important note from what that discussion there is that we've got an increase in numbers from people waiting for social care packages, but we are working together with our local authority colleagues to confirm a way forward in respect to that. And noting Linda's comment as well is that it is something that we need to improve, in preparation certainly for next winter. So there's opportunities there for us to put or further develop our plans in respect to that area. Okay, are there any other comments for Linda at all, please, on any of the issues that have been raised here today? No, nothing else is, no further comments. Okay, my apologies to you. I noticed that my camera keeps on going in and off and on at the time. I've obviously got a PC issue here, so we will. I'll get that. Well, so my apologies if I do go off again in the future and the remaining part of the meeting, but I am here. Okay, if I could go on to the next item, please, which is 6.21, which is the Organisational Risk Register. And I invite Callie Hamblin to present this report, which members have been asked to approve. Callie.
Thank you, Chair. Just a couple of notes for me until I open it up for questions. Just want to continue to report on the training. We've now trained 307 members of staff to date since we introduced the monthly virtual hour-long training last year, so that's continuing to be well received. Just this period, I've done some targeted sessions with district and community nursing, and also the patient care and safety function, which I hope you'll see comes through in the risk register updates, because they've done a lot of work around their risks in that function this period, re-articulating them, reviewing the mitigation, looking at the review dates. The entries on the organisational risk register have now been aligned to our new strategic goals as promised at the last meeting. Just would like to draw the board's attention to the points to note in the cover paper, where I've noted some emerging risks and also some of the areas where we haven't been able to update some of the risks this period due to some pressures in the service. The updates that we were formally requested as part of the organisation risk register fell in line with also our reset and our sort of perfect fortnight time. So some of the CSGs were unable to update their risk that period due to some operational pressures and challenges they were also facing. So the risk register continues to be not as up to date as I would like, and I appreciate that doesn't provide the board with the full assurance they might be looking where there is some review dates still past. But I just wanted to let you know this is a focus of our attention, and we do continue to raise this through the monthly risk reports and through our training and through the executive leads and their functions about making sure review dates. So I'll continue to ensure that that's a targeted focus going forward. The cover paper outlines any new closed or de-escalated risks this period, and as I mentioned, I've articulated and identified updates in red in Appendix 1. There is an emerging risk coming through because I've noted that in the cover paper that we've updated the CAMS risk this period 4149. That's further going through another iteration to bring in the forensic service this period. So that one is likely to be updated again, ready to come back to our May board. So I will take the paper and updates as read, but of course I'll open up for questions and bring in my executive colleagues for the strategic risks where they're identified as lead. So thank you, Chair.
Thank you very much, Callie. Are there any points of note or any comments you would like to make to, or questions you'd like to make to Callie, please? Nicola?
Thank you, Chair. Thank you, Callie. Callie, appreciating that you are working really hard on this. And there's quite a few comments that I'm happy to email you outside of this meeting because they're more around dates and updates. But there are just two datex that I'd like to pick up on if I could, please. And the first one is on page 2 and it's datex 4743. And it's in relation to security measures and fencing. And I noted that the dates are wrong anyway, because the last review was in October and the next review is September, so they need to be the other way around, I think. But there's no update on what's happening with the bid from estates. So it'd be really nice to know what's happening there, given the seriousness of the matter in estatex. And then the second one is page 7. And it's datex 3654 and it's on the gynae cancer services.
Thank you, Nicola. If I may introduce Gareth as the strategic risk owner, and if Gareth can answer, he will. If not, we'll take them offline. Nicola, if that's okay, and go back to the risk lead. Thank you.
Okay, if I could invite Gareth in then, please.
I'm desperately trying to do Control F2634 and it's not letting me, Nicola. So can I take that one away and come back to you on that?
Shall I just tell you what my question is, Gareth? And I'm more than happy for you to come back to me, you know, outside, you know, we can feed back to everybody. And my concern is it was last reviewed in May 21 with the next review for June 21. And the update that's in the action plan is exactly the same that came to board in November. The only difference in November's action plan was it stated that a task and finish group had been set up in June 21. But there's no update as to what's happened with the task and finish group and where we are since June of last year. So just if we can have some update on that, that would be great, please.
No problem, Nicola. Leave that with me. I'll get that across this afternoon or tomorrow for you.
Lovely, thank you. And Callie, shall I email you the other little issues I have?
That'd be fantastic. Thank you, Nicola, because I can pick it up directly with the risk owner in the strategic lead then. Thank you.
Great. Thank you, Callie. Thank you, Chair.
Thank you, Nicola, and we will make sure that there's a response made to the items that you raise outside the meeting. Thank you very much, Nicola, and thank you, Callie and Gareth. There are no further comments or questions I can see here, so can I ask colleagues that we're happy to approve the organisational risk register, please? Yep, okay. Thank you. If I could then go on to item 6.3, please, and this is Cwmtaf Morgannwg University Health Board as an anchor organisation, and it's an update on population health organisation project 24-30. I'd like to invite Kelechi Nohan to present the report, which members have been asked to note. Kelechi.
Thank you, Chair. Good afternoon, everyone. Members will recollect that in May 2021, this board approved a program of work to accelerate the Health Board's population health drive. There were about 7 specific projects within that program which focused on realizing the population health benefits of the Health Board being an anchor institution in our communities. As with many of the projects in the program, we were very clear about the need to properly baseline, recognizing that we needed to build on what's already in place in some of those projects. So this paper describes how we've mapped ongoing efforts in the Health Board in relation to the anchor institution objective, and it proposes next steps towards a comprehensive strategy for CTM realizing the benefits to our communities of its anchor institution status. I think there are notable areas of progress the Health Board has already made in this respect that are worth highlighting. So, for example, regarding workforce, over 200 members of the community have been supported in paid employment by the Health Board. Another 42 young people on universal credit will this year be employed through the Kickstart UK government scheme. In relation to procurements, enabling policy drivers are already promoting the pursuit of social value in the procurement process, an example being the 15% weighting of social value in contracts over £25,000. In terms of use of our physical assets, Glanreid Hospital is only the 2nd hospital in the UK to have been awarded a Green Flag Award for preserving green space on hospital estates. I think this is worth celebrating, and credit is due to our staff in estates and facilities for sustained efforts there. Despite the progress, however, we do have a long way to go. We're not using data metrics as well as we could. So, for example, we could use data better to baseline the proportion of our annual procurements that is spent with locally based suppliers. We need to know where we are so we can set a clear target for where we want to get to and then monitor our progress appropriately. In addition, we can improve consistent reference to best practice evidence from other anchor institution efforts across the country. Finally, Chair, I'd like just to observe that the anchor institution approach reflects the idea that CTM Health Board has importance and significant influence on key wider determinants of health and well-being beyond healthcare, and that population health agenda, when owned by the entire organization, can genuinely change the outlook for health and well-being in our communities. So I want to thank teams in workforce, estates, facilities, and procurement specifically, who have been and will continue to be critical in delivery of our anchor institution ambition for CTM. The board is asked to note the progress that we've made so far and plans to submit a proposed CTM anchor strategy to the Population Health, Primary Care and Partnerships Committee in May 22. Thank you. I'm happy to stop here and take any comments or questions, Chair.
Okay, thank you for Kelechi. Are there any comments or questions for Kelechi, please? No, there are no comments or questions there. Kelechi, can I just say thank you very much for a very informed overview of where we are as an anchor organisation and what the Health Board is doing to move towards that. So thank you again, Kelechi.
Thank you.
Can I then go on to the next item, 6.4, which is the approval of the integrated medium-term plan. And I'd like to invite Linda Prosser to present the report, which members have been asked to approve, please. Linda.
Thank you, Chair. I'd like to start by clearing up whether this is an annual plan or a 3-year IMTP. As you know, obviously we started this process with a 3-year horizon and have developed the document that you've got in front of you, setting out the context and some of the ambitions, which are 3-year ambitions. But in the process of this, as the board know, it became evident that we weren't going to be able to submit a balanced plan financially, and consequently the requirement for our submission to Welsh Government is actually an annual plan. However, I think that this document is still useful. I think it's useful to see the context and the range of activities that are being undertaken. All the deliverables that are in this plan are annual deliverables for 22-23. So we think this document does both meet the requirements for an annual plan and also is a basis for a 3-year planning horizon. Because of where we're at, we did have a meeting with Welsh Government in about a month ago, earlier this month, and they agreed that we could take another a couple of weeks, and at least till the end of April, to submit our final activity finance and particularly activity finance and workforce data, because of the need to improve our financial position and our performance position. There's some more work that we need to do. So we're recommending that we submit this as our annual plan in a draft form, to then be supplemented with that data later in April, which we're still working on. So what I'm asking for today is the recommendation that the board approves this document as part of our annual plan submission.
Okay, thank you, Linda. Are there any comments or questions for Linda in respect of what's been presented? Ian, please.
Yeah, thanks, Linda, and thanks, Emrys. Excuse me, I got builders in the background if you can hear drills going, so apologies for that. I just like to point out something very interesting in this, and congratulations to all those involved in the board, really, in taking a great innovation forward. And if you may have missed this, but on page 59, there's a table there, and number 10 on the table, it talks about NLP auto coding. And I think this is a really innovative approach to try and tackle a problem that's been with us for some time. We all know about clinical coding and the national issue in terms of getting enough staff to actually do the clinical coding job, and we've been working very hard at doing that. And this is really innovative in terms of trying to address that. It's taking what was a postdoc project forward, and essentially developing a process whereby you can take text of text that medical people have written, and use a method called NLP auto coding to turn that into SNOMED and clinically coded data. It takes a huge burden of the coding staff, and I'd like to sort of really congratulate everyone involved of taking such an innovation forward, and I'm sure it could benefit other boards in the future. So I wanted to highlight that, but yeah, congratulations to everyone involved with that.
Thank you, Ian, and well commented on. Thank you very much. Can I then invite Linda Thomas in, please?
Linda, I feel terrible going after Ian, who's like been sort of, really put something really interesting into the room. I read this and I was actually quite excited when I read the plan. I thought it looked really great. So I think it's a fantastic piece of work. And then I read it in combination with the performance dashboard that we've just discussed. And I guess my question is this a realistic plan? Is it doable? Can we as a board have assurance that behind this sits the right resource, the right workforce, the right metrics, that we're not just signing off something that sounds really aspirational and fantastic, but without any chance at all of achieving it?
Thank you, Linda. And actually, I had meant to say that I am excited about this document, because I think it does pull together so much of the activities that are going on across the health board, which and things are starting to come together. In answer to your question about deliverables, I think that is exactly why we've asked for that extra few weeks to do the detailed planning behind this. Especially given our financial constraints, and that's why some of the ambitions that are set here aren't for 22-23. They are things that we need to work on over a couple of years. But I think that where we stated specifically a deliverable for 22-23, that isn't aspirational, that is an actual intention. As I say, we just need to do a bit more work around some of the specific deliverables. I mean, as an example, I'll give you an example. A large amount of what we've talked about in terms of our recovery is in our elective care, and we're working with Grant Thornton, and in fact Malcolm's here for the next a couple of items time, and we're understanding more about how we can recover our elective backlog with core resources. We need to be better at that. in order that we recover, and we can use some of the Plan Care Recovery funding both to augment that, but also to support some of our other priorities. So I think, you know, that's why we wanted a bit more time to work that through in detail.
Can I invite Paul in as well, please?
Thanks, Emrys. Just really to follow up on Linda's question there. I mean, I think as Linda's rightly identified, this is a massive challenge, and I think, you know, we shouldn't be under any illusion. And again, this is not unique to CTM. This is a common challenge. I think, you know, probably these are some of the most challenging times for the NHS in terms of what we've got to now try and achieve. And COVID was a massively challenging period for us all over 2 years. Dare I say, I'd even think that probably what we're facing now is an even more challenging time, because we've got to carry on dealing with COVID whilst also trying to recover our elective activity. And as an organisation ourselves, we've got to continue the progress we've already made on some of our key improvements around things like maternity and neonatal care, the work we've done to improve some of our patient flow. We've got significant opportunities around digital transformation. We've got opportunities to become more efficient and use the value-based healthcare principles more actively in the way we approach some of our service models. So I think Linda Thomas has rightly identified that there is a huge amount to do. I think we also need to be realistic about what is achievable over the next 12 months and beyond, and that's why I think it is important that, you know, looking at our strategy work, we are looking at a broader time frame for that. But I also think we just need to highlight that the risks around this, particularly around the ongoing management of COVID, because we've talked a lot through this meeting today of the uncertainties, and there is so much that is uncertain about where we're going over the next 12 months, not with the, you know, the macro environment that we're dealing with politically, with the local environment that we're dealing with, and also some of the real challenges of COVID and the uncertainties what that will bring for us. So I think I would echo what Linda Pross has just said, is that, you know, it is a really exciting plan. I think we are at a really exciting time in our development as an organisation. Lots of really promising discussions with partners, both social care, neighbouring health boards, about how we address some of these challenges together. But of course that takes capacity and time of everybody, so we are going to need to be really efficient in how we use our capacity to make sure we focus in on some of those key strategic priorities. But I think it's a really exciting opportunity for us to really sort of put a marker down about where we want to be as an organisation, whilst being fully cognizant that there are some significant pressures and risks that still remain to our ability to deliver this.
Okay, thank you, Paul. Can I invite Sally in, please?
Thank you. I'm going to sound like the harbinger of doom at this point, but I think it's important for us to just reflect on the extensive discussions we've had about our financial plan, but also to reflect that's mostly been in board development sessions and for the sort of public consumption. This is not where we would want to be financially, but we recognise that there's a huge transition given our underlying deficit, and we need to do that safely and effectively in terms of mitigating that over a number of years. There are some very key risks within our overall position. There's a great deal of pressure on our sort of very small local service development reserve of £1 million. And as Linda says, we also need to make sure we're getting absolutely the best impact out of the 26.1 million that's been allocated for recovery funding. But I think it's just, I'd be remiss of me if I didn't just highlight that whilst we've got a core plan deficit at this point of 28 million, we have exceptional items that now sit at 29.3 million. We've had confirmation from Welsh Government that they will hold the risk around that, but the magnitude of the impact of just the direct cost of energy is now looking to be somewhere around 21.9 million for the health board for the next year. Now that is moving rapidly and moves around, but it is an incredibly significant figure that I think we need to be really focused on, because I sometimes think that in the wider public, the fact that we're also hit by these sorts of inflationary pressures isn't fully appreciated, and it does make a greater challenge for us in next year. We've also had confirmation from Welsh Government around some continuation of COVID response funding that will be allocated during the year based on actuals, but is outside of the programme expenditure that was originally identified. That is really welcome and does mean that we can start to taper our response more effectively to COVID as things emerge. So we've put aside, or we're estimating that at 16.5 million, but clearly that will change during the year. I'm very welcome in that it includes the cleaning standards funding, which is really important in continuing our IP&C response. So I just wanted to highlight that. And then just finally, we've also had some extensive discussions about the capital constraint. We're aware that our discretionary capital has been reduced by 24% this year, and that the All Wales capital pot is some 97 million lower than in 21-22. That presents real challenges in making service changes, particularly when we start to talk about digital. So we need to bear that in mind and work really effectively to make sure that we can consolidate with other health boards in terms of taking forward some of those proposals. So I just wanted to flag some of those issues, if that's all right. Thank you, Chair.
Thank you, Sally. Can I invite Carolyn in, please?
Thank you, Chair. Support all the comments that have been made. I wanted to make a comment about our academic partnerships, because throughout this very ambitious and very impressive plan, there's lots of reference to that. But I think obviously we will only deliver this with research, with innovation, with education, and almost right at the very end of the report is a little paragraph about research and development, which almost comes across as a kind of throwaway line. And I think it is all within the text of the report, but I would just want to see that emphasised a bit more, because it reads to me as if we're not really investing much in research and development, and I know that not to be the case, but I don't think that comes across from this plan. So I just would want that to be a bit more emphasised. Thank you.
Okay. Thank you, Carolyn. Can I invite Howell in, please?
Thanks, Chair. So colleagues will have noticed discussions this morning about workforce in a number of areas, really. So I just wanted to touch on that as a key area supporting the plan. So we are, like many organisations in the NHS in the UK, experiencing significant workforce challenges, and that will be something we'll need to get to grips with as part of this plan. Some of those are national shortages, but a lot of those are within our gift to do things differently. So there's a number of bits of work that we're taking forward over the course of this plan around recruitment, in particular overseas nurse recruitment for nursing, but also looking at some of our medical recruitment and trying to do that in a much more sophisticated way. And I think indeed the presence of a clear strategy and service plan will enable us to do that also. But also just getting some of our basics right to ensure that we're planning in the right way. We've got the best possible data in terms of what's going to come over the next few years, and increasing our discipline around workforce planning. We also plan in 22-23 to kick off a fairly significant piece of work, subject to some funding that we've asked for around that externally, around digital opportunities for our workforce. So working with Stuart and his team just to explore the elements of our workforce that we should now be planning that might have a more digital opportunity within them. So there's some significant pieces of work there, but I expect the workforce landscape to remain challenging. We are predicting around about 350,000 shortages in the UK health workforce by 2030. And that plays into a rather larger number in the global healthcare workforce. So it is going to be a challenging picture for us, but that's why we need to explore different workforce models and different ways of doing things across the board. So that's another key area of work for us over the next while. Thanks, Chair.
Thank you, Howell. Are there any further comments or questions from colleagues, please? No? Well, can I just say that noting the comments and questions made on this item, that we approve the approach taken to on the integrated medium-term plan, please. Yep. Okay. Thank you. If I could then go on to the next item, please, which is 6.5, the financial performance report. I'd like to invite Sally May to present the report, which members have been asked to discuss and note, please. Sally.
Thank you. Yeah, this is our report as at month 11. As at month 11, we're reporting a small underspend of around 600,000, but we're continuing to forecast break-even position. The key issue to highlight was the movement in the annual leave accrual. This is how we assess the non-taken annual leave, if you like, and the value of that, so that we are able to support our staff to either take their leave or sell back in accordance with the recently agreed plan around annual leave provisions. So we are have moved the accrual to it was 13.5 million, and we're now forecasting that will increase by 3.9 to 17.4 million. And we're planning to meet 1.9 of this increase from our existing budgets and are requesting additional Welsh Government funding of 2 million, which has now been confirmed. As we've talked about in many of previous reports, forecast savings during the performance remains lower than planned, and that continues to be a need for an increased focus as we move into next year. It has been difficult for our operational and clinical and directorate teams to engage with the savings agenda, given the many other strains and stresses upon them, but there's a clear need for us to get back to some business as usual around how we deliver efficiencies, and in that our approach to value-based healthcare will be incredibly important, as that will sort of focus us in the right direction. So rather than salami slicing savings, we're looking at savings that are about effectiveness and delivering the right services for our people. So our recurrent deficit is now being mitigated down as we've worked through the plan. We had a planned recurrent deficit of 31.4 million. It had risen previously to a higher level, but we're now setting it at 44.5 million going into next year. It's clearly a challenge, and that's been reflected in the last paper, which shows that whilst we mitigate that to an extent going into next year, we still go into the opening part of 22-23 with a £28 million deficit. So that's all really I really wanted to summarise at this point, but I'm happy to take any questions.
Are there any questions or comments made for Sally, please? I think there's no questions or comments there, Sally. I know that we've had several presentations leading up to where we are today to get an understanding of our financial position and also recognise what it is we're expected to do as a health board in moving forward, and that noting what you've presented to us today. So can I say thank you very much, Sally?
Thank you.
Okay, can I then move on to the next item, please, which is the review of the Cwmtach Morgannwg operating model, and I'd like to invite Paul Mears to present the report which members have been asked to approve. Paul.
Thank you, Emrys. Board members will know that we've been discussing recently, over the past few months actually, the operating model that was implemented in the Health Board back in April 2020, which was a product of work that was undertaken to review the structures of the organisation back in 2019. Obviously, these conversations about the operating model have been underway for quite a while. We were having conversations in August as an exec team about how the operating model was working, particularly given that the model had been implemented just as the COVID pandemic was hitting, the teams had to deal with some pretty significant challenges operationally through that period of time. I guess since I joined the organisation in September, I've had quite a bit of feedback from a number of clinical teams, in all parts of our organisation, acute hospital, community, mental health, primary care and other places, about the model and the pros and cons, and some concerns, it's probably fair to say, about the way in which the model was working, not individually within localities, but potentially precluding the opportunity for collaborating and working more effectively across the organisation, particularly on the acute hospital services side of the patch. We've been doing quite a bit of work in having conversations with the ILG colleagues about this over the past few months, and also having conversations with colleagues in mental health services, in primary care and others. So this process has been an ongoing sort of dialogue for a number of months now. But I think we also have reached the point where we do need to make some decisions about how we move forward with changing the operating model. That's certainly feedback that I've had from Welsh Government personally, and also it was raised in our JET meeting recently a few weeks ago about the perception externally that the model at the moment is fragmented and doesn't really give us the best potential opportunity to maximise the service changes that we need to make, and also the need for us to recover our elective capacity, our elective backlog, using the capacity that's available to across the whole organisation. I think it's important to highlight, the system group structure is also a key part of the operating model, and I think Linda has made a significant step forward in terms of focusing the system groups, who are now called strategy groups, to reflect the fact that they are very much part of the strategic approach to the particular areas they're responsible for, and that's certainly helped with the work that Linda's been leading around the operational strategy, the organisational strategy, but I think there is a real need now to make changes to the delivery model quickly, because I think we have a window of opportunity through the summer months and into the autumn to make any changes we want to make prior to the next winter pressure period, because we don't really want to be making changes to operating teams and models in the midst of a winter pressures period. So we have a number of programs of work now to kick off, I think, to move forward with changing the operating model. We've described in the paper the approach that we want to take, bringing together opportunities for the acute hospital services delivery into one structure under one of the Deputy Chief Operating Officers, Sarah James, to actually bring a greater degree of coordination of the way we deliver acute hospital services across the 3 sites. And then also making sure that we have under that Deputy COO a clear focus on planned care, so one person to lead on the elective recovery and planned care specialties, another person to lead on the unscheduled care work, so emergency departments, medical specialties, and also critically keeping the focus on the acute hospital site management functions. And it's also just important to highlight, in this model we're proposing, we would very much keep individual sites having their own site leadership teams, because it's really important, obviously, to make sure that there is clear identifiable leadership, both managerially, clinically, to lead what's going on a site on a day-to-day basis. And also we would then broaden that out to include a third area, which would be women's and children's, bringing together midwifery, paediatrics. Now, there are still further areas of work to do on this model. This is not a model that's currently at formal consultation. We're going through a discussion with a number of clinical service teams about this model, with the ILG leadership teams about the model, and also we've got further conversations tomorrow as an exec team about it. We know, for example, that Fiona and Lauren have made comments back about where the therapies function sits, which I think are very appropriate to be considered, and we need to make sure things like cancer services, diagnostic services are fully described in this model. But I think the key principles on the acute services side are hopefully clear from within the diagram you see within this paper on page 5. On the community and out of hospital side of the equation, the proposal, as you see here, is to bring together the mental health, primary care and community services together, so that actually we will still maintain 3 localities in our patch, but the proposal is that we align those localities with the 3 local authority boundaries, because there are some blurred boundaries at the moment between RCT and Merthyr localities. which I think sometimes can make it a bit more challenging, particularly when we talk about opportunities for integration with local authorities. So I think there is a big opportunity here with this new structure in out of hospital care to really bring together those primary, community and mental health teams in one. It very much aligns to the work that's coming out of the primary care teams around accelerated cluster development and the opportunity for us to really create one integrated team of primary care, community services staff and mental health, with the opportunity also to integrate further with social care colleagues as part of that. So I think it's a really strong opportunity to bring those services together. But also important to say this is not about fracturing out community services from hospital services. And we've talked earlier in the meeting today about the need for services to be very much aligned between hospital and community to facilitate discharges. And I just want to be really clear that the effectiveness of any model is not just about how boxes and lines are drawn on charts. It's also how we work and the structures we put in place around that in terms of meetings, regular get-togethers, culture of how teams work together. So it would be very much our ambition that the teams would still work in a very joined-up way between hospital services and the out-of-hospital system, and opportunities to have regular meetings and get-togethers to talk about common shared agendas, governance, risk, etc., would still be very much part of our proposed model. So we are, as I said, keen to progress this quite quickly. We are developing the processes now for moving towards this model. We've briefed the ILG leads and leadership teams about it. We've also briefed colleagues in nursing, medical teams, workforce team, HR, OD, finance teams, planning teams. Everybody in sort of the corporate functions that support the ILGs have also been briefed. But we haven't yet started, as I said, a formal consultation, partly because we wanted to make sure that the board was fully supportive of this way forward from today. So really, that is the summary of where we've got to in the conversation so far, Emrys. As I said, if we are in agreement today that we'll move towards this model as a board, then we will begin the next phase of development, which will be firstly further conversations tomorrow as the exec teams, and then we'll make sure that we share regularly with the board members progress against the key milestones through the project team, which Rich Morgan-Evans will lead in terms of the process of moving us through this next phase of the development of the model.
Okay, thank you very much for that, Paul. Can I invite Anna in for a comment, please?
Thank you. Just to say, there's been an ask from quite a broad range of clinicians about whether we'll get the opportunity to feedback. I think there's quite an anxiety that perhaps you've heard the negative opinions on the ILG structure, but there have been a lot of very real benefits, and staff are really keen to be able to feedback those benefits so we don't lose what has gone really well with this current model. And in particular, I think there's a feeling that perhaps some of the feedback has come predominantly from doctors, and there are groups such as therapies and medicines management who have voiced a concern that they would like the opportunity to also be able to feedback if possible. Thank you.
Yeah, no, thanks, Anna. I mean, absolutely, we want to make sure we listen to everybody who's got perspectives on this. There's never going to be a perfect answer in any of this, but it's really important that we listen to people, and absolutely, as you say, there are lots of really positive things about the model at the moment, and we want to make sure that whatever we do to change things, that we maintain the good things that have gone before, and that we also focus on the things and improve the things that perhaps have been not so great or been a challenge with the existing model. But we briefed, for example, the leadership forum yesterday. There was some feedback, and I've had some feedback out of that meeting from a couple of people about things, and we will, through the next phase of this process, put in place ways in which people can give feedback and comment on proposals and put forward their perspectives. So yeah, we want to make this as inclusive as possible as possible, but recognising we're probably not going to be able to please everybody, but at least if people feel that they've had the chance to put forward their perspectives and had the answer to why their idea hasn't been able to be taken forward, at least we can make sure we hopefully are listening to as many views as possible in taking it forward. I mean, I just also picked up the point that Nicola's made in the sidebar that, you know, We do want to progress on this relatively quickly because I am very aware, we've got a lot on our plates. We just talked about the challenges we've got, what the amount of work we've got to do over the next 12 months or so. So we don't want to get distracted into months and months and months of debate on this, but equally we do want to make sure there's the opportunity to do it in a way that is inclusive. So very much a commitment to do that.
Thank you, Paul. If I could invite Dom in, please.
Thank you for that, Chair. Yeah, it's just responding to Anna's comment, really, that I think there was also an interpretation of this model when we were discussing it, that we're moving away from a clinically led model, that we're leading to an operational model. That is not the case. It is very much a clinically led model. It's the terminology is such, this is our operating model, but we are maintaining at all stages the medical, nursing and therapies led aspects to it, which was one of the main good features of the ILG in the first place. And yeah, just reiterating that point about the pace of this as well, is that obviously that's come through from all clinicians' concern, is that are we pausing everything while we spend 6 months discussing and scratching our heads about the right way forward? No, and I think the concerns of the clinicians and also the exec board is that this has to happen at the same time as progressing the challenge that we have in front of us. So the two have to run in parallel. That's my only two comments.
Thank you, Dom. Are there any further comments or questions from colleagues, please? No. Can I just add then, just to add to what Paul just shared here, is that we are, in respect of this new operating model, we're consulting, we're listening, and we're looking at a way forward. And picking up both Paul's and other colleagues' comments, is that we want to do this in a timely manner, but respecting what we've got to do to achieve this, and the quicker the better, so that staff do know where they fit in relation to the changes going forward. So there are no further comments or questions there, Paul. So thank you very much for presenting that. But I have to put my final bit on here, is that can I confirm that we're happy to approve the new Cwmtach Morgannwg operating model, please? Yeah, okay, I've got approval for the proposal. Thank you, Paul.
Thanks, Emma.
Okay, can I then go on to item 6.7, please, which is Cwmtach Morgannwg 2030, Our Health, Our Future. And I'd like to invite Linda Prosser to present the report, which members have been asked to approve.
Thank you, Chair, and if I could perhaps introduce Malcolm, who is perhaps turn his camera on now. Thanks. Hi, Malcolm. Low Lowry from Grant Thornton, who's been working with us on our progress to date on this work. And I'm conscious of time, Chair, and the fact that we can't really do this item justice, but it might just be worth focusing in on Appendix 2, which is the kernel, because Appendix 2 is a set of slides which really demonstrates where we've got to in terms of the articulation of a set of priorities, of a way of working, some exemplar kind of vision statements, and where we're heading next. The covering paper and the appendices are really giving the board the opportunity to understand the context, the requirements that we're trying to meet, our needs assessment of our population, and some of the activities so far in detail. So you've got the big data packs, so that they're both in the public domain, and the board has access to those to understand what's being processed in order to get us to where we are. I think that some of this the board are familiar with. So on slide, on slide 5 and 6, we've specifically included the population health data as a brilliant indicator of what we're dealing with in our population and how we intend to target that. Slide 7, I think board members might have seen this before, the approach that we want to take to clinical services, which I won't read out, but what I will note, and I know that you've got the net zero plan in a couple of places in this document. It was with the IMTP because we've been asked to submit to Welsh Government as part of the IMTP But in our minds, this sits right in the middle of our strategy work. What's good for people is good for the planet, and vice versa. And we need to be designing our services to reduce our carbon footprint. And we articulate on slide 8 the care model, which is very much about prevention and supported self-care, integrated health and social care in the community, and then high quality hospital services, and an increase in people travelling outside of CTM for specialised services. And actually, as we've talked to the public, and we probably don't have time to go into that, they really get all of that. What we've invited Malcolm here because I thought it might be useful for people to understand a bit about how the workshops and the data packs have kind of got us to the point we are. Malcolm.
Thanks very much, and thank you for asking me along, Chair. That's very helpful. First of all, thanks to a very impassioned and far-sighted group of strategy leaders you have alongside your other corporate colleagues. It's been an interesting journey, and it's been great to tap into some of the stuff that they've been doing. But you'll see in those quotes on the slides that Linda has in the set some remarkable commonalities. And there's a bit of a segue between those commonalities and what you've just been talking about in terms of your future operating model, I would suggest. So a lot of what we found in those workshops was identifying things that were going on in different places, which were a bit unusual, a bit uneven. And repeatedly, you'll see phrases like join things up, join up the dots was language we were using a lot in the workshops. So you can get some evenness of delivery and of standard across the health board. And behind that, you can bring in the kind of innovatory changes you want to make. Retasking the workforce, developing new roles and all the rest of that. But sometimes it will mean some challenging questions about, for example, where you might concentrate orthopedics in order to do it in a way which protects it from the predations of urgent and emergency care. You know, it was almost a bit sad dealing with orthopedic colleagues who were desperate to get work to do, but the current organisation arrangements and the impacts on them, not just of COVID, but by the regular growth in urgent emergency care, stopped them doing that. Similarly, if you were into gastroenterology and gastrointestinal surgery, how can we achieve commonality of those services and an even standard and systems and processes which spoke to that? So there's a lot around getting standardized, having the right balance between what you require centrally as a health board and how that is articulated in localities, as opposed to starts to create differences within localities, and how you can then engage with a very committed workforce to go on the journey of developing its role and responsibility, not just in the hospital, but more widely across the system, connecting with their colleagues in primary community care, and sometimes in public health as well, in order to rebalance your model over the strategic period up to 2030. And a last parting shot is none of this will be any good at servicing the front end if there isn't a long-term partnership with colleagues in local authorities about the back end, because whatever you do about obesity with population mobilisation and the right kind of social support, as opposed to, if you like, clinical treatments, will be any good if around Merthyr you've got the kind of portfolio of choices for people in terms of retail, both in terms of eating out and in terms of buying, without local authorities helping you on that journey to create something at source which is a better offer, so that you're not simply dealing with the end product of this as opposed to the fundamentals for the population. But that was gotten by a very strong kind of centre of gravity and direction of travel from your own clinicians and clinical leaders. So thanks to them, and I hope this work, which is set out more broadly in Appendix 1, will be of use on your strategic journey. Thank you.
Thanks, Malcolm. And what I would add to that is that you'll see the read across then from what Malcolm's just said and what's in here to some of the content of the IMTP, and obviously what Paul's just been talking about in terms of the operating model. So this is looking ahead, but we are grabbing the things that we can do in the here and now. And I think I'll leave it there, Chair, if there's any comments or questions.
Okay, thank you, Linda. Thank you, Malcolm. For any questions or comments, if I could invite Paul in, please.
Yeah, just I wanted to thank Linda and Malcolm for this work. I mean, it's a really important part of our development as an organisation, but I also think it's important to sort of remind all colleagues that through this process, and I say this a lot, we're not going to suddenly produce a booklet for every specialty that describes where their service is going to end up. And I think sometimes when we talk about clinical services strategies, people think that we're going to go away and produce the plan that says this is what it's going to look like for you in 8 years' time, and start planning for that. This is very much more of an iterative process that we want to involve clinical teams in. There needs to be some clear principles in that, clearly, which are about how we move to a digital adoption as a core part of our service models, how we address some of the challenges in workforce that we've talked about, and finance, value-based healthcare. But I think really important to be clear with colleagues that anyone who's sitting here waiting for the date at which a big tome is going to land on their desk detailing every single specialty, you might be waiting quite a long time for that, because I don't think we will have that. But what we will have is a really clear framework for how clinical services will now progress through the model of approach that Malcolm and Linda have led with the strategy group leads in certain key specialties already. And I know there's already plans in place with Linda's team to look at things like intensive care services, orthopedics, cardiology, a range of other things now that we will take forward through that same process. But really positive, I think, to see the work, and also particularly now bringing together Kelechi's population health numbers and detail, which really set out the scale of the challenge, that will then help us design the way the care models that we need to have in place to respond to those particular demographics and population health issues can be designed. And I think it's a particularly exciting opportunity around the out of hospital care, how we use that data to really think carefully about how we bring all those strands together to respond to our particular population health challenges.
Okay. Thank you, Paul. Are there any other comments or questions for Linda or Malcolm, please? Okay, just to echo what Paul said there, you can recognise the amount of work that's got into development of our health, our future, and just thank you for all the work that's been undertaking. I know we as a board have had various parts of involvement in this through the process, so thank you again for that too. Can I just confirm with the board then that we are happy to, or content to, approve the Our Health, Our Future Cwmtaf Morgannwg 2030, please? Okay, thank you. If I could then go on to agenda item 7, please, which is the delivering our recovery and improvement plans. If I could go to 7.1, and it's targeted intervention and special measures progress report. And I'd like to invite Richard Morgan-Evans to present the report, which members have been asked to note. Richard.
Thank you, Chair. Good afternoon. Very quick rundown. The paper in your packs gives a very brief overview of some of the key activities since this board last met a couple of months ago. I'll just draw your attention to a couple of notable areas. So 28th February, end of Feb, we had a TI showcase session. The purpose of that session was to actually bring to the fore 2 areas of improvement in CTM over the last few months, PCH and the improvement activities there, which has met very strong positive feedback by HIW recently, as well as the activities led by Lloyd Griffiths over in T Lydiard, our CAMS unit, over in POW. Both of those items were very well received, and it was very good to be able to actually pause for a couple of hours and focus specifically and have a bit of a deep dive on these areas. So I think it was very well met. Back in February as well, the executive team had an escalation session, sort of a JET escalation with the Welsh Government, and again that was a great opportunity because it was the first time the team had an escalation session with the new leadership in NHS Wales and Welsh Government, with a new chief executive and deputy chief executive. We managed to go through a great deal of scope and improvement, and it met with very strong feedback as well. across all of the 13 TI domains, as well as special measures, which I know Greg will talk about much more in the next section. And that was great, and it was a real positive boost to get that feedback from Welsh Government, and it shows that the efforts put in by the SROs as well as their teams and all the relevant clinical, operational and corporate teams is paying off, and it has delivered a lot for the organisation over the last couple of years. We received a letter on the 3rd of March advising no change to the current TI sort of arrangements for now, and we've been given some pointers on some of the forward areas we need to sort of focus on. And the positive side of that is that there were no areas, I would say, that currently sit under our TI sort of domains that sit within those 6 points shared. Most of the points revolve around sort of performance and operational matters, so we'll continue to focus on them looking forward. Finally, in April, 28th of April coming up, will be our final sort of TI and special measures self-assessment session. So we've been doing this every 2 or 4 months over the last sort of 12-18 months or so, and we're at a stage now where a lot of these activities are very much sort of being embedded or have been embedded within business as usual, and are no longer really, or should no longer be seen as sort of a siloed activities that are seen as a project, but much rather just sort of BAU improvement. At the moment, in terms of our maturity, we're sort of starting to bridge results into maturity. So it'll be really interesting to see how we sort of fare at the end of April. And the feedback we got from Welsh Government a little while ago now was that's where they expect a health board in Wales to be. That's sort of bridging those 2 areas with elements of exemplar at times, and being able to sort of share knowledge and best practice. So we'll go through that, and I think looking forward, you know, we've just gone through the strategy and that emerging strategy, which we didn't have 12 months ago when I certainly joined the health board in terms of that emerging strategy. We have ICTM that have now released their business plan in terms of their improvement activities. And of course, as Hal would speak about, the leadership and management courses have kicked off in a very major way, covering all elements of leadership and management across the health board. So that's certainly the areas that will continue to take some of this improvement on, and will continue to focus on improvement across trust and confidence, leadership and culture, and quality and governance. And I know the SROs can speak very passionately about that. So I won't say any more at this time, conscious of time, but 28th of April, look forward to another self-assessment session. Thank you, Jeff.
Okay, thank you very much, Richard, for that report. Are there any comments or questions for Richard, please? No. If I could then go on to item 7.2, please, which is Maternity and Neonatal Services Improvement Programme. And I'd like to invite Greg Dix and Dom Herford to present the report, which members have been asked to note, please.
Thank you very much, Chair, and just a few comments from me before I hand over to Sally to talk through some of the detail around neonates. So out of the original 70 RCOG recommendations, 55 have now been fully delivered and verified by IMSOP. 10 required follow-up and are currently being triangulated by IMSOP following the site visit they did at the back end of February. So we're just waiting for some formal feedback around those 10. You'll see in the report, and Sally will go into this in a little bit more detail, that 42 further recommendations have fallen out of the deep dive for neonates, which, as board members will recall, are now integrated well into the overarching Mater-Neo improvement programme. Pleased now to update the board that all historic maternity SIs have now gone through our assurance closure panels within the health board, so the MDT closure panels, and just 10 are awaiting final sign off by the delivery unit. So huge thanks to our unit teams for not just focusing on the here and now and the improvements, but equally ensuring that the historic SIs were closed down. The job in hand now is to ensure that all of our women and families have been updated or will be updated on the outcomes from these historic SIs. We've just about completed the clinical review process for the neonatal category. Some sudden sickness in the team has caused us some anxieties in relation to pace. Nevertheless, we've got some time, Sally and I and the team, to get our heads together to ensure that that happens. You'll see in the report as well that out of the 160 original case reviews, there were over 1,500 actions, and in fact the team have worked remarkably well on closing down 1,400 of those specific actions, all been fed into the overall improvement work. And finally, Q&S committee a couple of weeks ago went into some detail around the clinical service metrics, which are presented by one of our CDs and heads of midwifery, some of which are in the report you've got in front of you today. And just finally, it would be remiss of me not to mention the publication of the Ockenden report. Yesterday, an independent review of maternity services within Shrewsbury and Telford NHS Trust. The interim report came out in December 2020, and some of the new board members, just to update you on a gap analysis we did at that time in relation to our own improvement programme, and we'll do the same now Ockeden's published the final report. On that note, Chair, I'll hand over to Sally, if I may, to talk through a little bit more detail of neonates. Thank you very much.
Okay, thank you, Greg. Sally?
Thank you, Chair. Thank you, Greg. As from the neonates point of view, as Greg has pointed out, the deep dive report was published in February and outlined 42 recommendations grouped into 5 topics, and the team are working through those and together with the escalation points that were highlighted in August of last year. We're making good progress. Excuse me. As Greg pointed out, we have some sickness within a very small team. However, we are continuing to work at pace and are continuing to work hard to complete these recommendations. As you can see on the highlight report, on the neonatal side, there are a number of areas that are in red and various reasons, delays in those pieces of work start, and I can now confirm they are all underway and we are making progress there. I think those are the main points I want to draw out, and happy to take any questions.
Okay, invite colleagues for any questions or comments, please. Jane?
Thank you, Chair. I just wanted to underline Greg's comment regarding the Quality and Safety Committee. We did, in fact, scrutinise very thoroughly the metrics presented to us at the meeting last week. One of the outstanding RCOG recommendations relates to the board scrutinising the performance of our maternity and neonates teams and services, and we're in the process of building a dashboard to actually give assurance that that is what we do, and we do it regularly, and we do it as part of our normal business. I mean, potentially we could add another set into the integrated performance dashboard, so it does actually become business as usual. But very happy to support this report and to encourage the board to note it.
Thank you very much for that, Jane, and thank you for your insight coming from the Quality and Patient Safety Committee too. Are there any further comments or questions that colleagues would like to raise with or share with Greg or Sally? No? Okay, thank you very much, Greg and Sally, for the overview of that report, and it's positive for me. It's very positive, both from 7.1 and 7.2 items, that the progress has been made within the health board. So thank you very much. Can I then go on to item number 8, please, which is any other business. Well, I've got 2 items for under AOB. The first is from Linda Prosser, and the second one from Fiona Jenkins. If I could invite Linda in, please.
Thank you, Chair. I wanted to make the board aware of a request that's come in from Mondachan and Taff Council over the last week, which is to support the establishment of a welcome centre for Ukrainian evacuees. Plans are still in an early stage, although moving apace, and we are responding with being prepared to provide primary care screening and relevant follow-up support for individuals that may come through that centre. I think there's still lots of questions still to be answered in terms of the numbers, the nature of the people that might arrive, and also how we're handling those who might arrive through a private route. So we're alert to all of that, but I thought we'd like to know that the work's going on, and we're starting to also understand some of the particular needs potentially of this group, vis-a-vis kind of communicable diseases, mental health issues, vaccination updates, uptake, that sort of thing, and of course maternal and child health. So we're just ensuring we're in a state of readiness.
Thank you very much for that update, Linda. We've got now if I could invite Fiona in then, please.
Yeah, I just put mine into the. I just wanted to say thank you to the board and to wish you all very well, and to save time I just typed into the chat instead. So I will have fond memories of you all. Good luck.
Thank you very much, Fiona, and you've been great asset for us in the health board too, so thank you. Okay, on to item 9, which is how do we do in this meeting? Just very briefly, I won't go into the details that we've got at the beginning of the meeting, because you'll be aware of these, but just to confirm, if is there anything that you feel that we could improve or change the meeting with, or offer any comments in today's board meeting? You can either let me know now, or we can certainly raise them outside of the meeting. There's nothing pertinent here at the moment. Okay, can I just say that well, there's one point I suppose I should raise before I go, is that we've had a few technical challenges today within the for the board meeting, and I know that we're going to be looking into them outside of this meeting. Can I just say thank you very much for your time, and the date and time of the next formal board meeting will be held on Thursday, the 26th of May at 10 o'clock. I now bring the board meeting to a close. I would like to extend my thanks to all who joined and observed the meeting today. Thank you.